So welcome everyone. And I do just want to apologize for slight technical Friday the 13th magic as we were starting, but it's incredibly exciting to be here today. I appreciate this was short notice and we're so grateful for everyone that's joining online, and we are recording. So without further ado, I'd like to introduce Donna McDonald-McGinn, who is a professor of clinical pediatrics at the Pullman School of Medicine at the University of Pennsylvania, director of the 22&U Center, and chief of the section of genetic counseling, associate director of clinical genetics, and the senior principal scientist at the Children's Hospital of Philadelphia, or CHOP. Phew. So for all of us in clinical genetics, she's the one that wrote the gene reviews, which is our go-to when we think about the first stop of getting information that we can try and help our patients and their families as we move from a diagnosis to wraparound care. So it's a huge honor to introduce Donna to you all, and we'll take it away.
Thank you so much, Emma, also known as Elizabeth, I understand. And if you're in the room, I apologize that I can't see you if you're on this side, as I am vertically challenged. It's my real pleasure to be here today to share with you the latest advances in 22q and 1.2 deletion and duplication syndromes. And I was asked to provide key takeaways from the 2024 International Scientific Meeting, which is really a challenge because there were 177 presentations over 3 days. So no pressure, Maria. So what I will do, though, is provide some background and highlight some of the presentations that we had from CHOP, and then talk a little bit at the end about the duplication. Let's see. There we go. So during this lecture, I will provide some highlights from the 13th Biennial International 22q meeting. I'll talk a little bit about how size matters, and that's regarding the nested chromosome 22q and 1.2 deletions. I'll share some atypical associated features and understanding variability. I'll share one novel intervention, which is around integrative health. And then, as I said, findings associated with the duplication. So what is the 13th Biennial International 22q Scientific Meeting? Well, this is a group of scientists and clinicians who have been meeting now for quite some time. It's hosted by the 22q and 1.2 Society, and I'm really very honored to serve as the Society's current chair. And we were happy to host this meeting as a true retreat in Óbidos, Portugal, this past July. Now, we were celebrating our silver anniversary on the Silver Coast, and here's a photograph of that first international meeting back in Strasbourg, France, in 1998. And that's me in the middle, essentially unrecognizable. And I was really quite honored to be invited to that meeting as the keynote presenter. And that's because the year before I had published this paper, which was on the 22q and 1.2 deletion report on 181 patients. And at the time, that was a very large cohort. You'll see how we've come from there. And we had the data because understanding the 22q and 1.2 deletion was a long-standing interest at CHOP. So Elaine Zakai and Beverly Emanuel, beginning in 1982, had presented this patient, shown on your right, who had a chromosome 10 and a chromosome 22 deletion due to something called an unbalanced translocation. And they suggested that this might be the cause of DeGeorge syndrome. Some years later, Debbie Driscoll, about a decade in fact, developed the N25 FISH probe and concurrently Pete Scambler developed the Tuple probe in the UK. And this new study, FISH, as you see on your left, was a turning point that set many investigators around the world on this journey, including myself as I developed the 22q Center at CHOP. Now, following the 1998 meeting, we have met 12 times, and I was really delighted to host the meeting with over 500 participants in Philadelphia in 2000. And then I've been very lucky to be a part of organizing the meetings the following years. We have in the audience Julie Wooten, who helped organize, I shouldn't say helped, she did organize the meeting in Coventry, England in 2010. And all of these meetings have been collaboratives with local individuals over the years. And our meeting has evolved to include an integrative health component, and I'm going to share some of the work of Maria Mascarenhas shown here later, but we've been very lucky to have her provide opening and closing breaths and really focus for these meetings, and they've included mindfulness, yoga, narrative medicine, etc. And the Portugal meeting included several CHOP Pen presentations, and you can see here that we brought lots of folks and they represented multiple subspecialties. And so today I'm just going to give you a smattering of some of the work that was presented there. And the participation of these folks really reflects the structure of our program Without Walls. So the 22q Center is at the core, and it's based in genetics. And then we have a primary circle of caregivers, and then the extended circle really does include the entire building. And we also have numerous research initiatives, which include collaborations with folks everywhere. Raquel Gurr, who's an adult psychiatrist, and I led the International 22q and 1.2 Brain and Behavior Consortium, which was 22 clinical sites and 5 genomic sites across 5 continents. And that has morphed into the Genes to Mental Health Network, which includes additional participants, including those in South Africa. And this has added the duplication to our research, as well as 16p deletion and duplication syndromes. Now, subsets of data that were presented in Portugal were from our 1,983 CHOP patients. So we've come a long way since 1998. I'm just going to admit the person and then get rid of this. But primarily the data we spoke about were from patients with the deletion, and that's almost 1,700 patients at this point. We have a bit over 200 with the duplication, and then 89 patients with distal deletions or duplications. So those that go beyond the traditional region that we think about, and I'm going to show you some of that in a bit. All right, I've stopped being able to advance. Okay. So in looking at our demographics of our cohort, 42% of patients with the deletion travel more than 100 miles to CHOP. And you can see the dark red, that's Pennsylvania, and we're located close to the orangey, which is New Jersey, which, by the way, is only 1 hour from some of the most beautiful beaches in the world. Not sure that they can compete with Australia, but they're beautiful nonetheless. And the mean travel distance to CHOP was about 400 miles, and for those within the US, 330. And we've seen patients from 49 of the 50 states, as well as Washington, DC, Puerto Rico, and 20 countries. And for the duplication, 18% of patients travel more than 100 miles to CHOP, and the mean distance is 186 miles, and we've seen patients from 18 states. Now, across all 22q and 1.2 copy number variants, there have been close to 250,000 encounters, including almost 83,000 outpatient appointments and 3,000 surgical procedures. And if you look at the average number of visits per patient, it's 55. So it just goes to show how complicated this diagnosis is and what this means for families as they have to come for so many visits. Now, patients with both deletions and duplications had on average 35 unique diagnoses. And the most common diagnoses included gastroesophageal reflux disease, and I'm going to talk more about that in a minute, language differences, and developmental delay. And if you look across here, some of the things you think about most often with the diagnosis, congenital heart disease, palatal abnormalities, hypocalcemia, are not there until you get all the way to the right where you see immunodeficiency, which is why we do need all the people in the building. Now, importantly, families value the coordination of the 22q Center. So using Press-Ganey survey scores, which is what you send out after a visit, 81% of respondents marked the top box for overall satisfaction. And our success is built upon our preferred providers who have become experts in their own right. And the continuity of care has an enormous impact on programmatic accomplishments. So if you look at some of the faces, you see them over and over at the meetings going all the way back to 2002 in Rome. And Dr. Elaine Zakai, who is the head of clinical genetics at CHOP, and the head of our program and the person who saw that patient in 1982 has been at CHOP for 52 years. And Dr. Emanuel, our laboratory director, still our laboratory director for this, has been at CHOP 50 years, and I'm in my 40th year. They would like to roll us out to pasture, but we haven't gone yet. Now, many of these folks that worked with us have gone on to lead impactful programs elsewhere, and that's also equally important. So Melissa Meisenbacher, starting on the left, works for Natera, which is a prenatal testing company with an interest in 22q, I think mostly because she's there. Shalagna Saida next is the head of the program at UCLA in Los Angeles. Richard Kirshner is a plastic surgeon who opened the clinic and runs it at Nationwide Children's Hospital in Columbus, Ohio. And then many of you know Tony Simon, who was instrumental in running the program at UC Davis in Sacramento, also known as the Mind Institute. So we continue to recruit and train future experts while always partnering with patients and families, because as you heard, this is the reason that we do it, right? This is the reason we get up every day. This is why you get up every day. And if it weren't for this relationship, I don't think any of us would be in it as long as we have. So looking back, it has been more than 30 years since the introduction of FISH studies to identify a chromosome 22q and 1.2 deletion, and not always in patients with typical features, as I showed previously. And this was described by your own Dr. Tony Lipson in 1994. And if you look carefully at this letter to the editor, it was in collaboration with our lab at CHOP, as you see Bev Emanuel and Debbie Driscoll's name there. And I think the reason 22q has moved forward so rapidly over the years, even though you all that are family members would say not rapidly enough, but in our community it has, and I think it is because of these international collaborations. Now, the deletion has often been found in patients with the triad of George syndrome, which is hypoparathyroidism, immunodeficiency, and congenital heart disease. And here you see 3 separate photos of Dr. Angelo DeGeorge, very close to our hearts. He was also in Philadelphia at the other children's hospital across town, St. Christopher's Hospital for Children. And he's shown here with one of our patients, with Dr. Zakai and I and our 22q bear, and Dr. Emanuel and Stephanie St. Pierre, who runs Chromosome 22 Central in Canada. And we were very lucky to feel like we were working closely with Dr. DeGeorge during this entire journey. So 22q and 1.2 deletion syndrome is now known to cause multiple conditions. Besides DeGeorge syndrome, we have velocardiofacial syndrome, which added palatal defects and some craniofacial differences. Conotruncal anomaly face syndrome, as described by the Japanese. We described a subset of patients with Opitz-G-BBB syndrome, adding hypertelorism, cleft lip and palate, laryngotracheoesophageal anomalies, which I'm going to talk about in a bit, and hypospadias in males. And then the Italians described Kähler cardiofacial syndrome, adding asymmetric crying faces. Now, these were all described prior to the association with the 22q and 1.2 deletion by clinicians concentrating on specific areas of expertise. So Dr. DeGeorge was an endocrinologist, Dr. Takal, a cardiologist, and Dr. Sprinson, a speech pathologist. And we sent this letter to the editor, to the American Journal of Medical Genetics in 1997 under the umbrella of what's in a name. And we used the analogy of myopic veterinarians trying to describe an elephant by examining separate parts. And each was quite good in describing their little area, the trunk, the leg, the back, the tail, et cetera. But it wasn't until you could step back and see the entire elephant that you knew what we were dealing with. And as you can see, we've colorized our elephant in the interim. So 22q and 1.2 deletion syndrome is now known to cause additional congenital anomalies, later onset conditions, cognitive delays, behavioral phenotypes, and psychiatric illness, all far extending the original description of DeGeorge syndrome. And I like to show this cartoon to families when I see them and talk about 22q for the first time, because they hear on the internet that there are 181 associated features, which is certainly overwhelming for families and also hard for clinicians to grapple with. So here I say the things in pink are common but important. The things in blue are less common but important, and the things in gray, such as an extra finger, can be a clue to the diagnosis, but they don't really cause a problem. They take it off in infancy and nobody ever knows you had that extra finger. Now, although common, lack of recognition of the condition and or lack of familiarity with genetic testing methods together with wide variability often delays diagnosis, which we believe could improve outcomes, including in adults often identified only following the birth of a child with congenital heart disease. Now, during these more than 30 years, the children have grown into adults, and we've learned much about the condition, including that the 22q and 1.2 deletion syndrome results in loss of about 50 genes, leading to a multisystem disorder with significant morbidity, lots of trouble, and some mortality. Some children don't survive. Now, genes within the deletion affect neural crest cell migration, leading to structural abnormalities of the outflow tract of the heart, resulting in conotruncal cardiac anomalies, absence or underdevelopment of the thymus, leading to immunodeficiency, and underdevelopment of the parathyroid glands, leading to hypocalcemia. This is the DeGeorge triad. So why should pediatricians care about 22q? I'm targeting pediatricians because we're sitting in Sydney Children's Hospital. Well, 22q and 1.2 deletion syndrome is common. It's been reported in about 1 in 1,000 pregnancies, 1 in 1,500 miscarriages, and just over 1 in 2,000 live births, making 22q and 1.2 deletion syndrome the second most common chromosomal abnormality after Down syndrome. And 22q and 1.2 deletion syndrome is the most common cause of syndromic palatal anomalies and schizophrenia, and the second most common cause of major congenital heart disease and developmental delay after Down syndrome. And 22q and 1.2 deletion syndrome is not related to advanced maternal age, so affected offspring are equally likely to be born to young mothers as to those with advanced maternal age. So based on a prevalence of about 1 in 2,000, and these numbers are a little outdated because I used the 2010 census, there should be about 163,000 affected Americans, including 35,000 children and adolescents. If we have the largest collection of patients with 22q on the planet and we only have 1,600, it begs the question, where is everybody else? And we believe that they're waiting to be diagnosed. So examining our CHOP cohort, we found that males and females are equally affected, and most patients are white. In fact, only 9% of our cohort are African American, and this is compared with our hospital population where 35% are African American. Now, we initially postulated that this might be due to a lack of typically associated craniofacial features and non-whites or some kind of ascertainment bias. But we've subsequently employed face-to-gene technology comparing 22q and 1.2 deletion syndrome related craniofacial features in 125 Black patients with the deletion to white patients with the deletion. And using this face-to-gene technology, we identified that the 22q associated craniofacial features were recognizable in both cohorts with similar accuracy. We then examined age at diagnosis and phenotypic features and found that the mean age at diagnosis is actually younger in our Black probands, and there was no significant difference in the prevalence of associated features, including congenital heart disease. So Bev Emanuel, again in our laboratory, has proposed that background differences in the size of the low copy repeats that result in new cases of the deletion are actually the explanation for the discrepancy in the overall prevalence in Black patients. In other words, those low copy repeats are different in white patients versus Black patients. Now, most patients continue to be diagnosed by genetics, but other subspecialists have improved their diagnostic rates, and that's a good thing. So we see lots of patients coming from cardiology or the cleft team, immunology, neurology, and even fetal medicine. We've seen about 165 patients now who were diagnosed prenatally and delivered at our institution. Now, common significant associated features still include immunodeficiency, congenital heart disease, and endocrine differences. And when we look at the heart, only about half have severe defects, and of those, most are tetralogy of Fallot with or without pulmonary atresia and interrupted aortic arch. But the most common heart defect is a VSD. 1 in 100 children are born with a VSD. So if we decided to test every child with a VSD, we would be doing a lot of 22q testing. The other thing that we see commonly, not surprising, are palatal differences, but we don't see a hole in the palate. We don't see an overt cleft palate. We mostly see a submucosal cleft palate or VPI where the palate isn't working properly. And then I'm going to talk about the GI differences, but those are some of the most common problems that we see, which were not recognized before. We see skeletal differences, including cervical spine anomalies and scoliosis. And then we relatively frequently see renal differences, so kidney differences, including single or malformed kidneys. Less frequent but significant features include other skeletal differences like butterfly vertebrae, craniosynostosis, limb differences, and patellar subluxation or fracture. We see central nervous system differences, including idiopathic seizures unrelated to hypocalcemia in about 15% of patients, polymicrogyria, spina bifida, microcephaly, and then you're going to hear a little later about Parkinson's disease. We see autoimmune differences associated with that immunodeficiency, most frequently ITP, JIA, and thyroid disease. But we also see hemolytic anemia, neutropenia, vitiligo, you name the autoimmune disease, and we've seen it, not so much type 1 diabetes, but almost all the others. And then in addition to renal abnormalities, I mentioned hypospadias, we see cryptorchidism, absent uterus in women, and inguinal hernia. And from an ENT perspective, laryngeal web and subglottic stenosis, choanal atresia. I'm going to talk about TE fistula in a little bit, hearing loss and sleep apnea. And sleep is a very important thing, and we think about that a lot. From the eye perspective, we see nearsightedness and farsightedness like anybody else, but we also see coloboma and sclerocornea, which is an eye emergency requiring corneal transplant. And then we see things that are just clues to the diagnosis, like tortuous retinal vessels and posterior embryotoxin. And lastly, we see malignancies more frequently than the general population, things like hepatoblastoma in an 18-month-old, Wilms tumor, renal cell carcinoma, thyroid carcinoma, melanoma of the tongue in a 20-year-old, melanoma of the vulvar area in a 12-year-old, and leukemias. And we think that those are immune mediated as well, by the way. And features leading to a prenatal diagnosis besides congenital heart disease include absent or small thymus, diaphragmatic hernia, polyhydramnios, the postaxial, pre and postaxial polydactyly that I mentioned of the hands and postaxial polydactyly of the feet. We've had lots of patients who were diagnosed with other conditions, including, for example, Smith-Lemli-Opitz, which is autosomal recessive with a 25% recurrence risk because of the polydactyly, clubfoot, which is very common, myelomeningocele I mentioned, butterfly vertebrae, hemivertebrae, and then umbilical hernia. So we see both inguinal hernia and umbilical hernia. Now, despite all these findings, unlike the early reports on DeGeorge syndrome, only 4% of our patients have expired. And those who did were mostly related to complex congenital heart disease. Some were secondary to airway issues, for example, tracheal atresia, with a median age of death at 5 months. So in general, if you survive the neonatal period, you will survive into adulthood. Now, developmental delay, cognitive deficits, and neuropsychiatric problems are common. So young children have mild delays in achieving motor milestones, and those with congenital heart disease, those delays are usually exacerbated. And most have significant delays in emergence of language, with a median age of first words at 19 months, median age of simple phrases at 33 months. And we've had some non-speakers as old as 5 to 7 years, but then the language comes in and it becomes a strength. We also have a subset of patients with autism, and certainly the entire group benefits from early intervention, especially speech therapy. And we are big proponents of sign language to avoid frustration. School-age children generally attend mainstream schools with academic and/or behavioral support, and the mean full-scale IQ is 76. And the majority of our patients have IQs that fall within the average to borderline range. But importantly, 65% have a nonverbal learning disability because they have a greater than 10-point split between their verbal and performance IQ. Now, that's not to say that they don't have language deficits, they do. But this is the opposite of the general population learning difference, which is usually a reading-based learning problem rather than mathematics-based. And when you put those scores together and divide by 2, it brings down the overall full-scale IQ. So we believe that scores should be considered separately, and this does really impact cognitive remediation. And this is a slide from Anne Swillen in Leuven, where we talk about how children grow into deficit with difficulty keeping up with their peers developmentally, difficulty keeping up with the environmental demands, which are primarily school, and with a decline in that full-scale IQ, mostly the verbal IQ falling to meet the performance IQ. And we have also published that that falling IQ may be a biomarker for developing psychosis, and we do recommend that the IQ scores be measured at least every 3 years. Now, the full neuropsychiatric phenotype is broad, beginning with neonatal seizures, which are usually what did I do now? I can't get out of it. Hide panel, and then hide them too. No? Maybe we can move them. There, they've been moved. So after the neonatal seizures, we have developmental delay and intellectual disabilities, autism spectrum features, attention deficit, idiopathic or recurrent seizures, sometimes called epilepsy, mood and anxiety disorders, and schizophrenia, as well as other psychotic disorders. And then, as I mentioned, we now know that we see neurodegenerative disorders, in particular Parkinson's disease, at a much younger age in adults with 22q. But 22q is variable even amongst identical twins, where one has congenital heart disease, the other one doesn't. One has medullary thyroid carcinoma, the other one doesn't. One has schizophrenia, the other one doesn't. So how do we explain such variability in this tiny piece leading to a big picture? Well, I would suggest not necessarily for the identical twins who have the same size deletion, but for everybody else, size matters. Now, most deletions extend from low copy repeat A to D. And as I mentioned, FISH probes are located within the A to B region. And the important developmental genes TBX1 and crackle are located between A to B and C to D, respectively. So B to D and C to D deletions do not include TBX1, which is the gene associated with abnormalities of the heart, the thymus, and the parathyroids. Now, in 2018, we reported nested deletions in 16% of our patients. So perhaps some variability and even under ascertainment may be explained by deletion size. In fact, in 2018, analyzing the IBBC data, Bernice Morrow from New York reported that differences in IQ scores were partially dependent on deletion size in just over 1,400 individuals with 22q, where 5% had an A to B deletion. So for Portugal, we examined deletion size and associated features in our cohort evaluated between 1992 and 2024 towards establishing genotype-phenotype correlations. Now, importantly, 328 of our patients were diagnosed by FISH alone, so they had to be excluded from this analysis. So standard A to D deletions were identified in 82% of our just over 1,300 patients, incrementally decreasing as our numbers grow because it was 84% in 2018. Also importantly, 7% of deletions did not include the A to B region and would be missed by FISH alone, and 5% were not mediated by low copy repeats. Now, we previously reported the mean age at diagnosis to be 3.9 years, and children with congenital heart disease were more likely to come to attention early, often sending children and their families without congenital heart disease on a protracted diagnostic odyssey. But the mean age at diagnosis is even older in patients with nested B to D and C to D deletions versus standard deletions. So you can see for the A to D deletions, it was 4.8 years, and for B to Ds, almost 9 years, C to Ds, almost 8 years. Now, we previously reported that less than 10% of patients with 22q and 1.2 deletions were familial. Now, when examining families where the deletion was sized, where both parents were available for testing, 14% of A to D deletions are familial, compared with 22% with A to B, 17% with A to C, and a whopping 71% with B to D and 67% with C to D deletions. When examining prevalence of associated features by deletion size, congenital heart disease was statistically significantly less common amongst patients with B to D and C to D deletions. Likewise, when examining severity of congenital heart disease, most patients with B to D and C to D deletions had simple or no cardiac differences, 90% and 85% respectively. And hypocalcemia was only observed in 2% of patients with B to D and no patients with C to D deletions, whereas growth hormone deficiency and thyroid dysfunction were relatively equally distributed. Still trying to get rid of them. Now, most patients had chronic infection, but those with B to D and C to D deletions were less likely to have laboratory-confirmed immunodeficiency. And patients with C to D deletions had no structural palatal anomalies, no structural brain differences, and relatively infrequent prevalence of scoliosis or ADHD. And when we looked at full-scale IQ, there was no significant difference across nested deletions alone, but when nested deletion scores were pooled and compared with A to D deletions, nested scores, like the Bernice Morrow paper, are significantly higher. Keeping in mind the numbers are small across all nested groups, and high-functioning patients had no reason to have clinical IQ testing. Now, what about C to D deletions directly, the tiniest deletion? Well, patients with C to D deletions have features similar to those with the standard A to D deletion, despite TBX1 being present. And it's important to recognize that the C to D region contains only 11 genes, but several are known to be important for embryonic development. So genes within the 22q and 1.2 C to D region include CRACL, which I've mentioned already, which is a renal and cardiac developmental driver, LZTR1, which is associated with autosomal recessive and autosomal dominant Noonan syndrome, as well as autosomal dominant schwannomatosis type 2, SNAP29 associated with Sedgwick syndrome, PI4KA associated with spastic paraplegia, polymicrogyria with cerebellar hypoplasia and GI defects and immune problems. And then SERPIND1, which is an autosomal dominant thrombophilia 10 problem. Then there are 5 other genes not associated with disease and 1 microRNA involved in post-transcriptional regulation. So we identified 32 individuals with a C to D deletion. They were diagnosed prenatally through age 40 years, and a mean age at diagnosis was 7.8 years. We also had 3 adults who were identified through a relative, so they had limited phenotypic data. 17 were female, and also importantly, 6 were found to have an additional copy number variant likely impacting phenotypic features. And this is important because 22q is so common that about 4% at minimum of our patients have 2 things unrelated to 22q. Now, 8 of the 12 probands inherited the deletion. I mentioned this before, 67%. And again, this is in contrast to the standard A to D deletions where about 14% are familial. And still they demonstrate broad inter and intrafamilial variability like the A to D deletion. So I'm going to show you a few families because I think they're telling. So this is the first family, and the proband presented with tetralogy of Fallot with pulmonary stenosis. So this sent off the test expecting a regular old deletion, and we're a bit shocked to find a C to D deletion. Parental testing followed, as we always test all parents, and the father turned out to have a C to D deletion. He has a master's degree in education, but he expressed that he had learning deficits in mathematics. Then we went to the sibling, the older sibling, and found the nested C to D deletion. And then when we looked at his kidneys, he had a missing kidney and he had some speech delay. And this family was key in identifying the important cardiac and renal developmental gene crackle within the C to D region. And we were delighted that this was published in the New England Journal of Medicine in 2017. Now, family 2 came to attention through the first pregnancy where they had non-invasive prenatal screening that suggested a 1 in 2 chance of the 22q11.2 deletion. The amniocentesis revealed a normal fetal karyotype, normal fetal FISH studies, and normal fetal microarray. And FISH was obviously directed to 22q. Maternal studies followed because sometimes you get that result because the mother has the deletion, and she had a normal karyotype and normal FISH studies. So the NIPT was presumed to be a false positive. Subsequently, she had infertility and pursued IVF. In the second pregnancy, amniocentesis for maternal anxiety revealed a nested C to D deletion by microarray, and then maternal studies identified a nested C to D deletion in the mother. Fetal ultrasound was normal. Fetal echocardiogram was normal. I'm admitting. I now know how to do it. All right. But I can't advance again. Ugh, sorry. Just when I get cocky.
Save you right.
There we go.
Okay. See, what did you press is the question. Oh,
No, you got it.
you back?
Okay, there we go. So to recap, mom was found to have the C to D deletion. The fetus had a normal ultrasound and normal echo. And when we looked at mom's history, she had growth hormone deficiency requiring treatment, hypothyroidism requiring treatment, anxiety requiring treatment, but she had no academic problems. In fact, she completed law school. So current detection methods still include FISH. And I will say, despite the fact that we developed FISH, we don't use it anymore. And I think this family highlights that MLPA and microarrays are preferred because they both size the deletion and they would not miss a nested B to D or C to D deletion. The other plus of a microarray is that it detects other copy number variants. And when a person sends the test, they don't have to be thinking about 22q. They send it agnostically and could come up with the diagnosis. Now, family 3 presented with a fetus that had prenatal findings of congenital heart disease, truncus arteriosus, a congenital diaphragmatic hernia, left lung agenesis related to the hernia, and an umbilical hernia. And a CBS revealed a 16p duplication, a 3p deletion. Whole exome sequencing revealed a change in a gene associated with congenital heart disease. And then parental studies followed, and it turned out that mom was a carrier of the 16p dupe, dad the 3p deletion, but completely out of the blue, mom was found to have a nested C to D deletion. This was an incidental finding unrelated to the fetus, and mom is a college graduate with really no history of anything except anemia. When we probed the family history, she has a relative with psychiatric illness and another member of the family who had an infant who expired with hypoplastic left heart syndrome. Oh, you're doing it to me again. All right, I'm trying. I'm not touching anything else. Okay. But this diagnosis in the mother is important for recurrence risk counseling, as she and potentially her relatives have a 50% chance of having a child with a C to D deletion, and comes with that the increased risk for congenital heart disease and renal anomalies due to the loss of crackle. But certainly, like everything else, the counseling is complicated by the broad variability. It's not going to advance. Is it hit the escape button?
Yeah, I usually go that, and I'll try that. Okay.
So it's not that I'm really going to talk too long. It's that this has slowed me down.
Okay, now what's it doing? It's just that. Get back and that one.
Yep. Okay. So overall, looking at C to D deletions, we see cardiac defects in about half of the patients, including tetralogy of Fallot with pulmonary atresia. We see endocrine differences, but not hypocalcemia. We see immune problems, but laboratory confirmed immunodeficiency is not so frequent. We see ENT differences, GI differences, GU differences, all the things that we see with the big deletion, just less frequent. And neurologically, we even have seen tethered cord and idiopathic seizures. We see anxiety, depression, ADHD, Tourette's, but not psychosis. We see speech delay and developmental differences, but developmental abilities vary greatly, and we have 3 adults with master's degrees. Now, notable absent findings include no palatal differences, no psychosis, but again, the overall numbers are limited. So patients with nested C to D deletions may have significant associated features as their findings overlap with those observed in patients with the A to D deletion. And this does provide the tiniest window into understanding genotype-phenotype correlations. However, the variability makes overall counseling challenging. And again, notable differences include the lack of palatal anomalies and psychosis, really requiring collaborative studies internationally so we have bigger numbers and we can see if any of this is in fact true. Now, overall, this data suggests deletion size significantly impacts phenotypic variability, particularly the B to D and C to D deletions where the prevalence of associated features is decreased or absent. And standard recommended screening is still necessary, as some patients do have the same features as those with the A to D deletion, likely related to haploinsufficiency of crackle. And I would recommend, Emma, that you use this rather than gene reviews, because it's more up to date and it's more comprehensive. And I'll show it again in a little bit. Now, this data is also key in providing personalized health care, and this is the one for the adults, for children and adults, as well as accurate recurrence risk counseling and opportunities, we hope, for really finding additional genotype-phenotype correlations, which may help to explain the overall under-ascertainment. Now, some atypical features, I'm going to talk about tracheoesophageal anomalies, and this was presented by Becca Wong at the meeting. So esophageal atresia and T fistula are rare anomalies occurring in about 1 in 2,500 to 4,500 live births. And it's important to note that there's a slight male predominance in the general population. When we look at these abnormalities, about a third are isolated and 2/3 are associated with other conditions, including VADR, single gene disorders like Charge and Fanconi anemia, and chromosomal abnormalities like trisomy 13 and 18. Now, tracheal agenesis is even more rare, found in less than 1 in 50,000 live births. Now, esophageal atresia was previously reported in association with 22q by Christina DiGilio in Rome in 1999. She had a female with the deletion and esophageal atresia, as well as congenital heart disease and a few other features. So we identified 8 patients with the 22q11.2 deletion and esophageal atresia with or without TE fistula. In contrast to the general population, 7 of 8 were female, and you heard the patient in Rome was also female. And when we examined deletion size, 6 had A to D deletions, 1 had a B to D deletion, and 1 had a C to D deletion. Now, importantly, the child with the B to D deletion also had a deletion of CHD7 associated with Charge syndrome, and you can see this in Charge, so it's muddy. And by the way, we have 2 patients with 22q and a CHD7 CNV or SNV. So of the 8 patients with 22q, 4 had esophageal atresia and TE fistula, 2 had esophageal atresia only, and 2 had TEF only. And 4 of 8 also had significant cardiac anomalies. In addition, we identified a male with tracheal agenesis with a standard A to D deletion who, as you can imagine, succumbed neonatally. And a niece of our patient with a C to D deletion and esophageal atresia and TEF also was found to have a nested C to D deletion. And a second Italian patient with esophageal atresia was diagnosed by Dr. DiGilio with a standard A to D deletion and congenital heart disease. So in total, we identified esophageal atresia with or without TE fistula in 1 in 200 patients with 22q at CHOP and 1 in 250 in Rome, which is 10 times greater than the general population frequency. We also identified tracheal atresia in 1 of our 1,600 patients, which is much, much greater than the general population frequency. Now, of note, 2 patients had nested C to D deletions, perhaps suggesting an association with the important developmental gene crackle, again located between C and D, as it is ubiquitously expressed and a known cardiac developmental driver. Thus, we have identified a clear association with 22q11.2 deletion syndrome and further defined the prevalence of tracheal esophageal anomalies in 22q. If you remember, we had suggested some of the patients with OPIGBBB actually had 22q. So this sort of also goes under that umbrella. And it provides a window into understanding the etiologies of these anatomic differences in the general population, specifically considering crackle as a developmental driver given the 2 patients with C to D deletions. Now, importantly, based on this data, we believe that the 22q11.2 deletion should be considered in the first tier differential diagnosis for patients with tracheal esophageal anomalies. Now, next, I'm going to talk a little bit about what Maria Mascarenhas presented in Portugal about GI manifestations. So, gastroesophageal reflux disease, or GERD, is pathological reflux with associated complications. The overall incidence is 0.84 per 1,000 person years. And after 1 year of age, the incidence decreases until age 12 years and then increases to maximum about 16 to 17 years. We previously reported GERD in 34% of patients of children with 22q at some point in their childhood. Enlarging our denominator to over 700 patients, we found GERD in 43% of patients, 54% male, almost all white, 87% with a standard deletion. Now, the mean age at onset was 2.2 years, and the mean age at resolution was 8 years plus or minus 6 years, and ranging from 3 months to 23 years. And no association was appreciated based on deletion size or familial versus de novo status. Now, associated conditions included Feeding difficulties, asthma, sleep problems, malnutrition. I came 26 hours. You don't want to hear the whole thing? And GERD was associated with lower anthropometric parameters, including height, weight, and BMI, as well as constipation and TE fistula. And 90% of patients with the deletion were diagnosed with TE fistula, had GERD. Therefore, GERD and TE fistula are nearly synonymous diagnoses in our population. Conversely, GERD is not commonly associated with congenital heart disease, infection, or developmental differences. Given GERD is remediable, early identification and treatment are important to the patient's overall care, as well as the family's well-being, as not being able to feed their child has been reported as the greatest struggle our parents face in early childhood. Similarly, we previously reported tube feeds in 8% of patients, with 4% requiring Nissen fundoplications. When we increased our denominators, we found that 14% of patients required tubes, and most started within the first month of life. NG feeds were started in 67% of patients, and those receiving NG feeds, 42% went on to have a G tube or a GJ tube, and the mean duration of tube feeds was 3 years. Comorbidities associated with tube feeds included GERD, constipation, congenital heart disease, and immunodeficiency. So we identified an increase in prevalence of children requiring tube feeds from 8% to 14%, and those requiring Nissens remained the same. Most patients started tube feeds within the first month of life and stopped prior to school age. And this data is really important to parents struggling to feed their infants and looking to 22q providers for reassurance that their children will ultimately PO feed. You really care about this part. So the importance of 22q and Tango 2. So as you heard, 22q is a multi-system disorder with wide variability, and associated features change over time. So for example, in childhood, we don't care about psychiatry in infancy, but we sure do care by school-aged and adolescence. Now, some features are affected by modifier genes, such as psychosis with polygenic risk scores, while others are explained by dual diagnoses unrelated to the deletion. So we have patients with 22q and SCID, 22q and CF, 22q I mentioned, and CHARGE, because 22q is common. But still other features may be due to dual diagnoses related to the chromosome 22q deletion in patients with a deletion on one chromosome, plus a variant on the remaining non-deleted chromosome 22. For example, in patients with craniosynostosis, short stature, anal anomalies, and skeletal differences due to variants in CDC45 on the non-deleted chromosome 22, unmasking an autosomal recessive condition known as CGS or Meyer-Gorlin syndrome. Now, there are multiple additional examples of such conditions, resulting in Bernard-Soulier, Sednick, autosomal recessive Noonan, Vanden-Ende-Gupta, and proline dehydrogenase deficiency, all with their own specific additional problems. But the most significant example is Tango 2 related disease, which was not highlighted in gray when I wrote this paper in 2015, because like CDC45, we didn't know about it. Tango 2 related disease is an autosomal recessive condition associated with dystonia, hypoglycemia, thyroid disease, rhabdomyolysis, metabolic crises, hearing loss, developmental delay, arrhythmia, and sadly, sudden death. At CHOP, we only became aware of the devastating impact of changes in Tango 2 on the non-deleted chromosome when we met Robert, who was diagnosed at 10 months of age, and Robert had all the typical features of 22q. But he had additional atypical features, including torticollis, episodic ataxia or dystonia, difficulty waking following anesthesia, staring spells, weakness, and extreme fatigue. And sadly, in 2015, Robert passed at age 5 following a brief illness. It took from 2015 to 2018 to make a diagnosis in hindsight, and clinical whole exome sequencing was normal, specifically targeting Tango 2. But we didn't give up, and an exon 3 to 9 deletion in the Tango 2 gene was subsequently identified in Beata Nowakowska's lab in Warsaw. No question, having Robert's diagnosis in its entirety was enormously helpful for Robert's family, as well as for his care team. We only wish we had known sooner, but as you can see, he died in 2015. It wasn't described until 2016. Since Robert's diagnosis, we identified variants in TANGO2 on the non-deleted chromosome in 7 additional patients. And 1 patient also has the exon 3 to 9 deletion. Importantly, some patients have no features of TANGO2, at least to date, including a young man who has a premature stop codon, who graduated from college, is fully employed, has had normal electrocardiograms. So this really makes the prognosis particularly challenging. Likewise, we have an adult female with 22q who came to attention after the diagnosis in her child with congenital heart disease. That child succumbed to prematurity because mom had preeclampsia. She went on to have a second child who died because of preeclampsia, and now she has a child with 22q who has survived. She had the studies as part of research, and the only atypical feature that she has is the preeclampsia, and she too has had normal EKGs. So when examining expression in lymphocytes, the patient with the exon 3 to 9 deletion has almost no expression of TANGO2, whereas those without variants have variable expression. Moving forward, identifying the prevalence of variants in TANGO2 is extremely important for the entire 22q community, as TANGO2 related disease is such a potentially impactful diagnosis. Concurrently, we need to better understand associated features, variability, and mortality risk. Excuse me. No question, working with the TANGO2 community is the only way we're going to do this. As Christina Miyake and Sam McKenzie have suggested, vitamin B complex is an important treatment strategy for TANGO2. And they're recommending vitamin B complex as treatment for all patients with 22q until they've had TANGO2 testing. I'm just going to quickly go through integrative health, which is mindfulness, meditation, all those things. We think it's a good treatment for anxiety. We've surveyed families to see what they know about it, and only those who were well-educated and had older children were familiar. As you can see, most had a college degree, but all listed barriers to seeking integrative health therapy as a problem with costs and difficulty finding a trusted provider. Following on this, we began a research study where we're going to examine psychosocial wellness, cortisol, metabolomics, and gut microbiome in patients 7 to 12, undergoing an 8-week one-on-one wellness course. Excuse me. And recruitment for this is ongoing. We did it because we had a 12-year-old who had terrible nausea, dysphagia, and abdominal pain, and they couldn't figure out why. He had fungal infections in the gut and was treated with antifungals, but he still had trouble. And so they thought about using acupuncture or acupressure. And in fact, his mother, a physician, was trained in the placement of auricular acupressure seeds and told to change them after 5 days. And currently his symptoms are well managed, both with medications as well as the seeds. And he has not missed any days of school since starting acupressure. And he actually goes to his mom every Sunday night and asks for his seeds to be changed, because he reports it's the only thing that helped him with his belly pain and nausea. And we're really pleased to present this patient, and we hope, following the results of our Be Well study, to increase awareness about integrative therapies to be used in conjunction with standard medical procedures. And we know that Linda Campbell has been doing this, and Sasha Dweef, and we think it's going to be really important for the 22q community. So I'm just going to have a couple of slides about the dupe, and then I'm done. So we've evaluated 272 patients with the duplication. The majority have a standard duplication, but there are way more nested duplications than deletions. The clinical indications for testing most frequently include developmental differences. Associated features overlap with the deletion. You see hypocalcemia, thyroid disease, heart disease, but hypoplastic left heart more frequent here, and total anomalous pulmonary venous return. Growth is an important problem associated with this. You could be too big or too small. And 40 to 50% of patients fall either above or below the curve for height and weight. No, I'm just escaping because I just can't forward. And I can't escape either. Just leave it like this. It's fine.
Okay. Back to the presentation.
No, I was going to say it's fine to just leave it if it'll work.
Oh,
Okay.
okay.
Most probands have developmental differences, about 90% overall. And males were likely to have developmental delay in autism compared to females. So to think about a typical patient with the duplication, it would be a male who has macrosomia and macrocephaly presenting with autism. And a subset of patients had IQ testing, and the mean full scale IQ was almost 83, and 43% of our overall cohort scored in the average range. And most duplications, unlike the A to D deletions, are familial, 62%, and they're almost equally inherited from mothers and fathers. And most parents had no associated features. And really importantly, 3 parents have doctoral degrees and 1 has an MBA. And this really makes it difficult to prognosticate for the child or to recommend parental screening. So patients with the 22q and 1.2 duplication are being referred to 22q centers for care, often with features overlapping the deletion, frequently with growth disturbances, but without any published guidelines. We're not sure how we should follow patients. So we are currently employing the deletion healthcare guidelines, the pediatric, the adult, and the prenatal until more data becomes available. So I'm going to acknowledge my collaborators at CHOP and around the globe, because it really does take a village to care for a patient with a chromosome 22 copy number variant. And enormous thanks to Rick Guardati for many of the beautiful faces of sunshine that you saw in this presentation. And I'd like to thank the patients and their families for everything that they've taught us, because just like that patient of Dr. Zakai's in 1982, it always begins with a patient, and we need to remember that. And thank you for your kind attention. And if you have questions and you want to email me, it's mcginn@chop.edu. They had to pick one of my names. Thanks so much.
Okay for a few questions?
Oh, you want me to do questions?
You're right.
Yeah.
Thank you. Okay. So please, can everyone join me in thanking Donna for an incredible talk that covered a huge amount. And we just wanted to acknowledge we started late, and Donna's come an incredibly long way. So we really wanted to make sure that she had a chance to give us a fabulous update. But also, we're very open to any questions. So I'm going to try and check the chat, which was a lot about the sound at the start. Has anyone got any questions? Yep. So David said, thank you very much, Donna. That was an excellent overview. Honey, have you got a question? We could just see you beautifully. I think you've wowed everyone.
I've got a question.
Yep.
With regard to the Tango 2, I saw that you said that prior to, I've got a fairly loud.
You need it for the.
Oh, okay.
people online.
With regard to Tango 2, I saw up there that you said prior to testing for Tango 2 that it is recommended now for, was it vitamin B? Is that what you said?
Vitamin B complex.
So are you saying that all children should have that now and all should be screened for Tango 2?
So the recommendation from the Tango 2 folks in Portugal was that the vitamin B complex are quote unquote a Flintstones vitamin, and they didn't see a downside. Now, that's not to say that everybody should go out and take the vitamin B complex without supervision of a physician, because B6 in particular can be a problem if you take too much. And so Maria Mascarenas is our GI person. She is now going to be our lead vitamin guru at CHOP and see patients and make those recommendations. And in the meantime, we're sorting out how to do the testing. And why do I say we're sorting out? Because as you heard, our patient had clinical testing for Tango 2 and it was missed, even though we told the lab to be sure to look for a deletion as well as a variant. And the Tango 2 folks recently had another patient who was missed for the same reason. So we're working on what lab is going to do it. Clinically, Beata Nowakowska is an expert in the other allele in Poland, and she's happy to do it on a research basis, but research means no timeline for getting an answer. And that is not her fault, but it's complicated because she runs a clinical lab and does prenatal testing and things like that. So while we're waiting, the recommendations from the Tango 2 people are that vitamin B complex should be taken by all patients with 22q. Again, under the supervision of a physician.
Is it working? Yes, it is. Okay, thanks. That was an amazing amount of information. You're talking about about IQ scores and that the change in those showing an increased prevalence towards schizophrenia. So is that when they come together, the verbal and the non-verbal?
When the verbal starts to drop in particular, but any change in IQ score is a concern for the onset of psychiatric illness, and that would be a knee jerk to be seen by psychiatry. And it's the reason we ask for periodic IQ testing in all of our patients. Keeping in mind in the US, I don't know what it's like here, it's very expensive and insurance generally doesn't cover it. And so that's why you only saw a subset of our patients who have had the testing.
Right. Is there any kind of physical medical tests that you can do? I remember reading something about for onset of schizophrenia that there was some kind of protein in the eye or something. Is that something that 22q patients?
There was a discussion about the tortuous retinal vessels associated with psychosis, but I don't think that was confirmed. We have like an entire potpourri of our a la carte menu of research studies that people can participate in. And one of them is a scratch and sniff test. So decreased sense of smell is associated with schizophrenia. So we're now doing smell testing in all patients moving forward as well. And it's associated with differences in the structure of the olfactory bulbs. We're also doing imaging. We have some, as I said, there were 177 presentations. We had some great neuroimaging data and things that look like they may be biomarkers for psychosis, but still very preliminary.
Thank you.
Any other questions from the room? Oh, online? Okay. So there's a question online. Is there benefit for those who were initially diagnosed through FISH to now get a microarray? So FISH is that earlier chromosome type of test we used to have.
So we think there is, because of some of the data that's coming out now showing differences. If you had a positive FISH test, in all likelihood, you at least have the A to B region missing. Could be A to C, likely the entire A to D region. But given that we're seeing some differences in long-term outcome, especially if it's a young child, it would be worth having the definitive sizing.
And just for Australians, your microarray is covered by Medicare. So that's something that's publicly available.
I have one more quick question just to follow on from Leanne. With the psychosis, obviously, is something that all families and parents worry about. Your International Brain Behaviour Consortium, that research was in particular looking for psychosis and autism. What is the actual prevalence, and is it as high as it used to be?
So we weren't looking at prevalence in that study. We were looking for modifier genes and found that those families who had lots of background genes associated with psychosis were more likely to have a child with 22q who developed psychosis. In terms of prevalence, as you know, in the literature, it's listed anywhere from 25% to 40%. But most of those folks who are reporting those prevalences work in psychiatric institutes and they see patients with psychosis. we work in a place where we see children with congenital heart disease, so we have a higher rate of heart disease. In our cohort, we've seen our patients convert to psychosis in less than 10%, and about half of our patients are over the age of 18. Keeping in mind, the average onset of psychosis is 15 to 25 years, but we and others have had patients as old as 30, 32, 35. But in general, when you get over that age 25, you are generally outside of the risk range.
And with regard to that, in the general population, it's just to bring it back down a little bit, because it's a scary topic, right? So in the general population, what is it approximately that psychosis occurs?
1 in 100.
There you go.
So it's still much higher compared to the general population, and it does give us a window into understanding why it happens and if there are better treatments. And there were lots of talks about treatments there as well. And so lots is coming. And the fact that the entire world is working on this is a really good thing.
So my prerogative, can I ask one question? I was fascinated by the ear acupressure thing, because we see across many neurodevelopmental conditions that gut dysmotility is a huge issue. Do you have any thoughts on how that's working? Is it reducing anxiety, or how is that working? Do we know?
I'm not sure that anybody knows the exact mechanism of how it works, but we know about the brain-gut axis in general. And it seems to be that those patients have high anxiety in general, in addition to dysphagia and nausea, et cetera, and headache. But it worked. And so that's one of the reasons we're doing this study moving forward. And the study is looking at all aspects of integrative health. So they're training families one-on-one, mindfulness 1 week, anti-inflammatory diet another week. And for me, the most exciting part is obtaining the microbiome samples, because we'll know what it looks like in the beginning, which no one has ever done in 22q. And then we'll see if this changes over the course of treatment or remains the same. And we'll look at things like how many antibiotics did they take. And the boy that we showed actually had many, many years of antibiotic treatment. And so it's all complicated, but I think it's important that we start.
Yeah, absolutely. It's really, really wonderful. Thank you so much. That was just an incredible. Oh, one more question, Lord. Last one. We'll dock it off your time.
Thank you, Donna. That was insanely impressive. I was just wondering, so we kind of know that we're underdiagnosing, we're wondering where all these children are with 22q. Should we be encouraging children with a diagnosis of autism to be going and getting genetic testing, do you think? Because we see autism quite a bit and we see autism as very prevalent, and maybe some of our 22q kids are hiding under that autism diagnosis, perhaps.
So at CHOP, we see all patients with autism and send microarrays on just about everybody. So yes, I think it's a good idea. I've had a conversation recently with a cardiologist who said, well, should I be sending every child with a vascular ring? Yes, you should be sending every child. So I think, it's like saying, do we test everybody with a VSD? 1 in 100 patients. Do we test everybody with autism? I think in the long run, we're going to be testing everybody with anything, right? Because as prices come down, as it becomes more standard of care, and I think until we do that, we're not going to find everybody.
Honey has just said that would be the practice. And she also said about the incidence for psychosis, that it's much less than reported for the team. I'm just reading it.
And I think that's important for parents to hear, because there's no question you get through the 55 appointments that are mostly heart disease, palate, immune, so many chronic infections, so many ear infections, so many tubes, right? And then you get to school age and you think maybe I'm okay. And then all of a sudden you're worried about what's going to happen next. And is that shoe going to drop? And so I think the vast majority of the time it will not drop. But to follow things like IQ, to be seen by somebody, whether it's in a research study or clinically, to monitor things is really important, because the minute something happens, the earlier the diagnosis, the better the outcome. It's like anything. The brain is an organ like anything else. All right. Thanks so much.
Thank you very much. And yeah, it's interesting. Even I've got a PhD student who's looking at the importance or considerations around genetic testing with autism. I guess we know that the yield is pretty low if that's the only feature. But someone has to have a completely, interrogation of all of their health to know that. But what we haven't heard from is the perspectives of autistic individuals about their perspectives. So there's some interesting conversations happening around that space. But with no further ado, I would love to introduce Dr. Laura Roche. So she's a senior lecturer in special and inclusive education from the University of Newcastle and the co-leader of the Developing Minds program. Is that right? And she advocates for a strengths-based approach to learning for children and youth with neurodevelopmental conditions. Her work is focused on improving the way young people with these conditions, such as autism, communicate with others and navigate their world, starting with acknowledging their existing abilities, understanding their needs, and working in close collaboration with their families to implement evidence-based interventions. And now what I'm going to try and do is share her slides, which was on the desktop. Which one's yours? The top one. That's what we all do, is we label our slide 22Q. And then if I go, oh no, that was the wrong thing to do. So
Presenter mode.
yeah, that's what I need to do. I need to share the screen, take a deep breath, go to this one, share, and then come back here. This is where I need my ear seeds. Is this working? Can you see online? Brilliant. And you need to use a thingy. No. I move like that. I know. How do you move? Just click. I know how to do this. I can do the proper acknowledgement now. I've got it.
Thank you so much for inviting me here today, Maria. Actually, I think I recommended that I come. Thank you so much, Donna. A bit of a big presentation to follow. Donna has massive numbers and massive data, and I'm like this big. So my name's Dr. Laura Roche. I'm a senior lecturer in the School of Education. So I'm a little bit different in this field all the time, not a geneticist or an actual medical doctor. I would just like to acknowledge the support I've had from Associate Professor Linda Campbell from my university, who we all know very well, Dr. Tracy Flynn, a speech language therapist, and Associate Professor Honey Heussler, who will be talking soon, and also Professor Jeff Sigafus from New Zealand. A lot of this work is done in association with the 22Q Foundation and also with obviously my university. So I just want to acknowledge the beautiful and unceded Awabakal lands that my research was conducted on, that's up in Newcastle. And I just pay my deepest respects to the traditional custodians of this land and all lands that we are on. And we're very lucky to work and learn here. So I'm going to be talking a little bit about social communication, which is really the focus of my research. I got into this field because I started in neuroscience and psychology. I sort of moved into educational psychology and worked a lot with young children who were minimally verbal with autism. And I noticed that there's a massive discrepancy in sort of some of those early intervention and supports that children with autism receive as opposed to other children who have a more rare genetic syndrome or condition. And so my research has always been around functional communication and effective communication skills, and then more leading into the social communication side. So we know a lot about 22Q in terms of social communication. There's been some incredible research done well before my time in this field. And I read a lot of Cynthia Salot's work from Donna's hospital and her team, and they are absolute pioneers in this field. So I'm definitely still learning, but I've noticed a few things along the way from my work in 22Q. So we know that speech and language disorders are very prevalent in children. We know that we see lots of speech sound and speech difficulties due to mostly physical issues, VPI, cleft palate sort of issues. And this can often result in unintelligible speech, which affects articulation. We see lots of hypernasal speech in our children. But we also know that speech issues exist without a physical reason as well. And we also know that language issues are very persistent across development. And in some of the work that I'm doing at the moment, it's really after intensive speech language therapy and surgeries in these young children, we're seeing that the language issues are becoming more of a problem for the older individuals. So what is the focus of what I do? So first of all, I actually look quite deeply into AAC, which is augmentative and alternative communication systems. So it does include things like keyword sign or sign language, but there are also other really well evidence-based practices that have been used for young children with autism that can also be applied, I believe, to some of our children with 22q. And that is largely around using picture-based systems to support sort of development of communication and also support spoken language development as well. And also things like iPads or sort of more high-tech devices that can really support that social communication as well. I also have been working a little bit trying to understand exactly what's happening on the ground in Australia around 22q. So I've been doing a few surveys on speech language therapists, both here in Australia and internationally, and looking at how our really young children are supported in early education centres as well. And I also, in collaboration with Maria and the 22q Foundation, have sort of developed a bit of a social cue program for our young adults with 22q that really looks on building social connections between young people with 22q and also their families. So that's a bit of a prelim program. It's very new. So a little bit on my social communication intervention. I presented on this a couple of times. I've really only started scraping the surface here. So I worked most recently with one little boy who has very hypernasal speech to the point where he is very unintelligible. So even his mother and father really struggle to sort of understand what he's trying to communicate. And so with this little case study, we worked on AAC, and we used a visual system. So down here, you can see this was his hex system. He's a very intelligent young boy, and he can actually speak Turkish and Russian and English, but the fact that he was just really unintelligible, which was making him really kind of nervous around his communication attempts, and he would often give up and become really, really frustrated. So we tried a visual system, so PECs, so that he could request snacks and play in a really easy, kind of nicely prompted way. Mum led the intervention within the family home. We used all his own toys, all his own favorite snacks, and she was really empowered because she was, you know, running all of the sessions with him. So what he would do was sorry, I'll just show you. He would pick up his little symbols saying, can we, then he'd choose play, and then he would choose out of his little play activities. We also did this with snacks. And once he had formed his sentence, he would then verbally repeat the sentence while pointing to the pictures to do his full request. So when we use AAC, we're not just focusing on using an iPad or just focusing on the pictures, we're also encouraging the speech as well. So in no way does this sort of, you know, change or demise the importance of speech. So results were pretty great. He learned really quickly. Again, it's only one child. In baseline, this is called a single case experimental design. So it just shows that we can still show an effective intervention even with really tiny sample sizes. He learned to do independent requests with his pictures using speech as well, and he maintained these sorts of high levels of skills and follow-up. Anecdotally, he started forming little sentences on his strip, but changing the item he wanted to play with because it wasn't available. So he would be annoyed at the limitation of his system and start choosing other things that weren't available. He also, I watched him do this, would walk around and point to the TV and be like, I want TV now and I want this. So anecdotally, he was actually generalizing his skill as well. And he was using that full sentence. So at the beginning, he would point and vocalize to something he wanted. And now he was trying to say that full sentence, which was really nice to see. Again, case study of one. Moving forward, that child, we are now working on some simple narratives to help him actually tell a little bit of a story about something that's happening because he's going to be going to school next year. So we're really trying to extend on his sort of language skills there. So again, I don't have all of my notes here because I can't do the presenter slide here, but I ran a survey looking at what speech and language therapists are doing with young children with 22q, how confident they feel in working with some children with 22q based on what they know about the syndrome, and whether they're using AAC to support their children with speech and language difficulties. It was really, really interesting because I found that a lot of our speech language therapists didn't know a whole lot about 22q to start with. They were working with children using some AAC. They requested that they wanted more support with AAC. And this was interesting to me because in the literature, you cannot really find research studies that publish on the use of AAC for children with 22q. I have found 3 currently, and one of them is mine. So there's recommendations, especially from Donna, to use, sign language to help with frustration. And obviously our speech language therapists are using AAC with these children, but no one's publishing on it. So it's really hard to know which system works best for these children, the best kind of intervention methods or support strategies we can sort of use. And what I'm really interested in is when these children are going to school, how can we support them in their communication skills at school? Because what we know about 22q as well is that the social narratives of these children is somewhat delayed or, less complex than their typically developing peers. And so a lot of the time that's when they really struggle to make those friendships in early childhood and in primary school. And we know that those social relationships are really protective. So I'm really interested now in how we can sort of use AAC to extend social narratives in young children with 22q. I've also been doing a little bit of work with some students around early childhood educators and how they feel that they know how to support young children with 22q within their centres. We've got a couple up in Newcastle and even more down in Sydney. So this is very preliminary work as well. But the initial findings from small scale surveys is that these educators are really keen to have more support about what 22q is and how they can actually support young children to socialise with their peers when they're in their settings. And now I'm just going to briefly talk about social cue because I think I've got a few more minutes. This is a really cool program. I only have 8 participants so far. I'm hoping to get another cohort running up in Brisbane. But you can see these are my Melbourne kids that I just finished a program with. And the other photo is my Sydney crew with their parents. Both amazing groups of young people who at the beginning did not want to join my program at all. Had to be really encouraged by both their parents and the fact that I was giving them gift vouchers at the end of the program. But they are just some of the most incredible young people I've ever met. So the program is aimed at young people with 22q age from 15 to 25. And it's really interesting that Donna just said, that is the height of when we're going to see psychosis coming on. It's also a point in Australia where a lot of high school students are thinking about leaving high school. Massive, terrifying transition for both young person and parents. It's also a time when some of my older individuals have left high school and are now wondering what they're going to be doing. And it can be a really super socially isolating time where a lot of these young people are actually just staying home and not going anywhere. And this was one of the main reasons why some of their parents were really keen to get them enrolled in this type of program. So as I say, this is pilot data. I actually sort of struggled to get enough people. I wanted 5 in each group, but 4 actually ended up working out pretty well. But I guess because of the distances and some of the complexities around the syndrome, it was a little bit tricky to sort of navigate sorting out these 2 programs, but we got there in the end. So the program begins with pre-assessments with both mum and sometimes mum and dad and with the young person. So I conduct assessments like the Vineland Adaptive Behaviour Assessment, the SRS, which is a social responsiveness scale, which just sort of interrogates how the young person is responding in social situations, social communication, how aware they are of their social engagements and social situations. And also a communication checklist that looks at both adult and child participants. I also did a lot of sort of like a clinical interview with the parents to find out as much about the young person as I could, previous challenges, diagnostic history, how they go at school, what sort of social relationships they have, what are their goals, and what are their personal kind of identified challenges or strengths in terms of social skills. I then met with the young person on Zoom, which again, they never really wanted to meet me. And it was so great. I think it's really challenging to make a young 18-year-old like you on Zoom because so much was resting on that first Zoom session. They may or may not have joined my program. But they're all really beautiful young people. So we had a Zoom chat to talk about their life, their interests, thank you, and what they wanted help with. So sometimes in the literature, we've found that actually young people with 22q, they don't need any help. They're doing just fine. They don't need any help from you. And it's mostly their parents who are saying, no, they could do with a little bit of help. So all of my young people actually identified that they did need a little bit of help, that they would actually like some more friends, that they actually don't really know how to read body language very well. So during these Zoom sessions, we also watched 4 videos of different social interactions, and I kind of interrogated their knowledge of what had happened. So sort of relaying back the social experience and what that individual did wrong to make it awkward, and maybe some solutions, some social solutions. They also did a little pre-questionnaire. So this is a little bit overwhelming, but what this tells us is that in the SRS, which is the social responsiveness scale, often used in part of an autism diagnosis, a lot of these kids were in the severe social impairment range. So really having trouble with that sort of social responsiveness in their daily life. I only had one young individual from Melbourne who was actually scoring in the, she didn't have any severe issues there. In the communication checklist, every single participant had clinical challenges in social communication skills. And in the Vineland, which is all about adaptive behavior, I just focused on daily living skills. So these are all age equivalency scores. I'm actually missing a Vineland from one family that I need to follow up on. But largely we see at least 1 to 3 standard deviations below the means across daily living skills. And this is being independent in looking after yourself, operating around the home, doing dishes, doing your washing, and also operating in the community. So a lot of challenges going on here. Our sessions looked like the first session and the very last session we met face-to-face. I thought it'd be really important to have a little bit of a hybrid model so that we actually met each other so we could make those connections, which was really important. And the young people, although they told their parents they didn't want to go, they actually, got engaged, started talking, and seemed to have a reasonably good time. I also, in the session 8, I went and bought them all milkshakes and stuff. So there was a lot of, reinforcement going on there. But the sessions 2 to 7 were all on Zoom. We did them once a week. And we started with a reflection of our week. So I always got everybody to tell me what they've been doing, what they're up to, were there any wins, were there any losses, anything that was challenging in that week. And we talked about school, we talked about going to a cafe and freaking out about ordering. We talked about a whole range of things that were happening and also all the good things that were happening. So then every week I would ask the young people to ask each other a question about what had happened previously. Sometimes it was like getting blood out of a stone, but sometimes, they started to warm up, became a bit more friendly with each other, a little bit safer, and we got some actual conversations sort of happening. We also talked about what we learned last week, what we're doing this week, and it was full of trying to share stories about our lives. They also had little homework tasks they had to do. So the topics we looked at were conversations. So I had to really tailor this because, every one of our 22q young people have different levels of skills and are, some are really, conversations. I don't need help with that. And others are taking notes. So conversations actually ended up being a really good one because I just gave some really good tips on, how do we keep a conversation flowing, which was really challenging for these young people. We talked about inner speech, so what we tell ourselves. And it was actually really interesting. Some of the young people really opened up about what they say to themselves in different social situations. And we looked at trying to flip their script a little bit. Also noticing and reading others' body language, which is a really important one. Emotions in me and emotions in you. Identifying whether someone is a bully or a friend. I was very adamant that I'm not sending them out there to just make friends with everybody, that we have to be discerning. And also powerful thinking and goals. So we all talked about our goals for next year. So the results, I don't really have hardcore pre and post assessment data because it wasn't big enough sample sizes. It wasn't really long enough. I probably wasn't going to get massive changes in their SRS. But we did do the pre and post questionnaires. So I really found out how the young people engaged with the program, which topics they found useful and what they actually got out of it. And really importantly to me, they all felt like they made a connection with the group. They found the program to be helpful. They specifically found conversations, emotions, and inner speech to be really useful. They all felt really safe, comfortable, and they liked the format, and they even would prefer more face-to-face, which I was happy with. The parents, I gave them a TARF, which is like it assesses how much the parents found the intervention to be useful. So the parents were satisfied with the program. They loved the topics. They thought that it was helpful for all of their children. Some parents wanted more involvement, but all of the parents really highly valued the connections that were made, because when we would have the face-to-face sessions, the parents would all go off for a coffee and they would chat. And sometimes it was the first time that a parent with a child with 22q had met another parent with 22q. So things that I would like to do next, or things that I think that we should know next. Really interested in play in young children with 22q. How can we support them to engage more with their peers? I'm always exploring further AAC use to find out best practice. And also, in general, what is best practice in early intervention and psychosocial support for our young children? And we can't see that. But my overall goal is just developing meaningful psychosocial support for young people and their families who have 22q. So thank you very much.
Ooh. Okay, beautiful. So just checking if there's any questions at all. Yes, Donna's got a question. And so I need to, it's just so people on.
So first off, I want to know if we can clone you. There are some genetics people in the room, because it's fabulous, and I think you could make a business, not that you want to have a business. We all need this for our patients, but what would you do, because we have a handful of young adults who don't want to have 22q. They don't want the parent to have the sticker on the car. They don't want to come to events, and they certainly don't want to come to a meeting or get into a Zoom call. And yet the families are struggling with all of the same things. How do you think about approaching those patients, and how do you help them?
That's a really interesting question. One of my young people in Melbourne, their parents didn't really talk about 22q, and her mother said to me, she doesn't really know that she has 22q, which I found quite interesting. But within this program, we never really talked about 22q. We just talked about how do we feel in this situation and what do we do? So it wasn't, and it was called social Q, but that doesn't necessarily have, there was no, 22q wasn't involved at all. I did ask the first Sydney group, because I was maybe feeling a little bit bold. I sort of asked them a little bit about 22q and what they think about it, and I got some pretty interesting responses there from them. But with the older ones, I didn't really think it was necessary to make it a 22q thing necessarily.
I just meant, how would you get them?
How would you get them
come
there?
if they
Yeah.
don't want to recognize that they have anything?
Yeah,
Like,
that's
why
true.
why would I need that? There's nothing wrong with it.
I think if they're still at school, there might be a chance to have something integrated into school that could be, because I think, you know, if you're doing it with everyone, then it's not a special thing. You're not being isolated. And I think that's the biggest thing, right? If you're already a little bit anxious about your skills and you're a bit worried, you don't want to be isolated further. I think also for those, I mean, nobody wanted to do this program. None of these young people wanted to even meet me on Zoom. One of the girls I met was hiding under a blanket when I was Zooming her, and she slowly came out from under her blanket. Reinforcing, I took them out. I made it tried to make it a little bit cool for them. And I gave them gift cards. I forgot to mention that, but I had to really try and reinforce with those tangibles, make it not about 22Q. And I think trying to embed it into something else that's not focused on 22Q would be a wise move. If they're in some sort of assisted program after school or something, you could try and maybe get in that way. But it is a little bit challenging. I mean, if they don't want to do it, we can't force them into doing it, can we? What we can do in such cases is probably provide the parents with strategies and get them to start those conversation tips. And personally, what I would do is probably coach the parents around what you could try and do in the home and talk, like topics to talk about. Because some of those topics I talked about, like in a speech, the parents were like, what's that? What's going on there? And we know that that's really important in our mental health and how we view ourselves in social situations. So I think if we really can't get the kids, then we've got to coach the parents.
So I'll just bring to a point where Donna wasn't privy to our, not last year, the meeting before, where at our conference, our annual conference and dinner, we asked Laura to be our facilitator for young people. There was no expectation. It was sort of designing this program that you've just done, your social cube program. And so we invited them all along, and they went into a room with no expectation or anything. I had no idea what was going on in the room. And all the parents are like, oh, should we allow them to go in there? Really? Without us? What's going on in there? There was numerous parents doing that. And I just said, no, this is their safe space without us as parents. And we let you go. And we couldn't get them out of the room. It was like, guys, we're finished. We've got to go to dinner now. And I think whatever you did in the room would really work at one of your family meetings. And also educating the parents to let go. Let these children do it and normalize it. It doesn't have to be, you have 22Q. It's just a thing. In our house, it's just a normal everyday occurrence. Of course, I'm a bit privy to a lot of information and a lot of experience, but it is just an everyday occurrence. It's not, we say, you're not special just because you have this. It's just something you have to deal with, and we all deal with it with you. And you don't have it. Don't you tell me you deal with it. And you know that one. So I think in the home, normalizing it, not turning around it to hide it. It's a bit like anything really, sexuality, why do we have to hide things these days? You shouldn't have to. So that's normalizing it. But I think that your program will get there even more, and those kids and the parents just need to, that's where I was going with this. I saw your statement up there that the parents wanted more involvement. But as you as a teenager, if you as a teenager, did you want your mother in the room?
Yeah, no.
I don't want you to hear what I'm about to say. And that's what they want. And I think we have to normalise that too.
Yeah.
So good on you, Laura. It's a really good program, and I hope that we can expand it for you. And I know that somebody in the room here is really keen. So have that baby. Greece is only 2 years away. Yeah.
Was it pointing?
Thank you. I just want to say in New Zealand, Laura, that the AAC is well used throughout all schools. And probably the biggest thing for parents and carers is if you're not happy with your speech therapist and they don't have the information, give it to them. And that's how we've got through with Lachlan through school, is by giving the information. And just saying, look, you're not working for us. Let's move on and find someone else. We actually had a speech therapist who sat down with me and said, I finally got my 22Q child. I want to make things happen. And we had her for a whole year, and he had the best movement forward in that 1 year with her because she was passionate. So yeah, I think it comes back to parents and caregivers in that particular situation that we need to educate people, because it's hard for speech therapists to know every condition. So yeah, thank you. I know. Well, that the 22Q education booklet, it's in my handbag all the time.
Beautiful.
So I'm going to introduce ourselves, I think, if there's no other questions. Very good. So what I need to try and do is share my screen, just double checking if there's anyone online. Yeah, yeah. Yeah. And Honey was just saying, depending on time, she's happy to talk tomorrow.
Or even at another time, Emma, they've all heard me before.
But we love you, Honey. All right. Honey, can you tell me if oh yes, share sound. Oh, very good.
It is, okay, good.
It is? Yeah. Okay. Is this coming up and you can see the screen?
It is. There's a big banner across the top of it, though.
Yeah, so that's what, escape? No. More?
have to hide the menu.
Now there's another one down the side.
This guy? Okay. And then how do you advance?
There we go.
Oh, beautiful.
That's better. Yep.
Fabulous. So people can see us and people can hear us. Yep, I'm going with yep. Okay, fabulous. Well, I'm Emma. I'm a clinical geneticist at Sydney Children's Hospital, and I'm a researcher at the university. And this is my very dear colleague, Eva. Would you like to introduce yourself?
Definitely. My name is Eva Sternadová, and I work as a professor in special education and disability studies at UNSW. And I have a great privilege to collaborate with Emma on the GeneEqual project. We are using in this presentation the principles. Thank you. The principles of easy read English, which you might be aware of, because our team is very much grounded in being inclusive. We work together with researchers who have intellectual disability themselves. The whole team has took the training in easy read. All the team materials that we use are in easy read, and this is just acknowledgement that we use PhotoSymbol prepaid database.
So as Eva mentioned, we have very, very important chief investigators in our team with intellectual disability. So you'll see there Julie Loblins, who got the Order of Australia yesterday, not yesterday, last year. Who is an incredible self-advocate. She's a mother and she is one of the most brilliant researchers, I must admit, that I have ever worked with. If you can see, I'm not very good at keeping to time, but Julie keeps us to time very well. We're also rather unique in we're a combination between health and education, genetics, disability studies, and ethics. We don't have very many Y chromosomes between us.
We don't know why.
So we started, and I must say part of this came from some recognition. I've been a clinical geneticist for some time and worked with a beautiful senior genetic counsellor, and we were often doing genetic testing on people with intellectual disability, but I realised that we'd never really stepped to think how we could, what was that experience like for people with intellectual disability themselves? And so that's where we started, is we actually did a literature review which showed that hardly any studies had been done. And then we were able to get some funding from New South Wales Health to do some interviews and focus groups and co-production workshops to hear about people's experiences. And then we took those experiences together to make an educational toolkit. So I'm going to hand over to Eva to hear what she and Julie heard.
So we have interviewed 19 people with intellectual disability about their experiences with genetic testing and counseling. And these experiences were often very negative. People talked about being treated as somebody who has no capacity to understand, to make decisions and to make changes. People also talked about a lack of accessibility of medical practitioners, not being able to explain things clearly. They talked about other barriers, such as people only or the genetic practitioners talking only to their parents or support people, never really talking to them, though they would understand. They also mentioned the inaccessibility of the conditions. And it's, if you think about the conditions and how we name them, it's really hard. I struggle to understand the name of this syndrome that the conference is for. And I wonder how easy it is for people who have to, carry that label. So we need to be also more inclusive in that sense. And we will have here people not only talked critically about what's happening, but they also gave us many suggestions what can be improved. And one of our fantastic researchers, Sky Sarfaraz, will now talk and tell us about the suggestions.
People made suggestions for how things could improve. Some examples are as follows. For doctors to explain things well, to stop and listen so the patient can receive and process the information properly, for them to talk slowly because sometimes they talk too fast and use too much jargon. The doctor needs to stop and check that their patient understands. And they need to use pictures where possible, and also easy read, which is kind of like what you have on the screen here, a picture on one side and words on the next. That's a simple example with bullet points and shorter words. Give people choices and use languages which make people feel respected.
So this is an example of a co-production workshop led by Julie. And what you can see here is we've got people coming together who are giving us their feedback as we're developing resources together. And we also spoke with people within health and different clinicians, as well as self-advocates. So this is what we made, and my glamorous assistant will distribute some of the booklets that we co-produce, which we understand are the first easy read booklets about genetics. And we really started on topics that people with intellectual disability and learning difficulties asked us to start with, which was really about why should I care? And a lot of what we did was, I'm going to let Astrid in, we started off talking a lot about DNA and genetic codes, and then we kind of scrapped all of that and went back to the why people may like to think and know more about their genetics, but also why they might not, and the importance of choices. And we did a series of videos. Take one is the experiences that people said that they had in healthcare. And take two was a way of doing that aligned with those recommendations that you heard Sky telling us. The interesting thing when we did an evaluation is every single person with intellectual disability resonated with the poor practice type 1 and said that they had experiences or much worse, whereas quite a lot of clinicians said that could never have happened. Surely that hasn't happened, that kind of trauma, stigma, abuse in the health system. So we also have a whole range of education for healthcare workers about how to improve the accessibility. And we've got a short video we're going to try and show just to give you an idea of what people thought about that kind of co-production.
The GeneEqual project is a multidisciplinary group of researchers and people with intellectual disability as co-researchers that aims to make genomic healthcare more inclusive and accessible to all by foremost listening to people with intellectual disability.
It's about supporting people with intellectual disability, and it's important to be able to make sure that there is better healthcare. And today's workshop was all about getting client feedback on the resources we developed with doing videos and booklets.
And it really is an important step on achieving the goals of the national roadmap for improving the health of people with intellectual disability. And we got some absolutely amazing feedback and really just some new ideas what we can do further.
So one of the key things we heard today is people really valued having both videos. They liked that healthcare professionals should see the first video and be reminded or maybe pointed out to them things that they may be doing unconsciously. And then followed with the second video, which gave them some great strategies of practical things that they could do to change their practice.
Some of the other things that came up today in the workshop was that people with intellectual disability felt it was valuable that they also saw the videos, and that support people and family members also were able to watch what good healthcare looks like, so that we can empower them and they can recognise what good and bad healthcare looks like.
I think this project is really important because we've seen people with intellectual disability speak up to their doctors or ask for things to be explained to them in a better way, so it's already making a difference.
Yeah, I think what Skye said is so important, that what we've heard from people here at SAS is even by being part of the co-production workshops, they've learnt more about their rights and the rights of all patients across Australia, and that's made a difference in their lives. So that's what we want to do. We want to make sure that everyone gets the right sort of healthcare, that they know their rights, and that doctors know how they should be doing healthcare as well. Trying to work out how to move it on. Next. Oh gosh. Okay, 1 second. Here. There. Oh, moving the same thing.
I don't know, are we sharing? Can people see on the Zoom? No, we stopped sharing. We need to start sharing screen again. Yes, sorry.
All right, hopefully that will work.
Also, you can keep any of them if you want to, and you can share with your loved ones. So moving on in our presentation.
This is just to say that we're actually been bowled over, that it's over a quarter of the world have seen our toolkit, which kind of just shows that there's a real gap there. And we've been very grateful to get some funding to extend our project for 5 years for a national project. And we have a dedicated stream, including people who are Aboriginal and Torres Strait Islander. We've done a lot of work around what helps people make their own healthcare choices. And our amazing student Manjika Dunn published this article, which was voted the second top article in the BMJ Safety and Quality for last year, which is quite a big journal. So that was great. We've talked to lots of people to get their experiences. We've particularly talked a lot to families, and we've talked to people with intellectual disability who do not have a known diagnosed genetic condition, or who haven't ever had an encounter with a genetic healthcare service. And we want to change that because we would love to hear more from young people and adults with a whole range of different genetic conditions, whether they've either had a genetic test as a baby or even before they were born, and just coming up at that last question to try and understand what would they like to know, and how would they like to know that, or wouldn't they like to know that? Just so we've got some information to help guide us as we move forward.
And just to say, so if you want to share this information with your loved ones, that would be fantastic. The interviews are done either on the Zoom or in person. In our experience, many people with different conditions prefer in-person interviews, and we are very happy to travel to do those interviews. Interviews are conducted by Julie Lobinsk and I, and we really work very well together in ensuring that the interviews are accessible and safe space and comfortable space for the people we talk to. We also would like to hear from more from families, so from parents and carers, about learning what their loved ones learn in high schools about genetic health literacy. Because what we're finding out that people, adults with intellectual disability, no matter what the condition they have, they are also very often ill-prepared for engaging in healthcare service, make decisions, really think about how to make choices in healthcare. And funnily enough, actually the national curriculum, including life skills, does include components about health literacy and genetic health literacy. We have already spoken to some young people who study high schools in Australia and also to their teachers. And the issue is that the teachers choose not to teach this content because they don't know how to do it in an accessible manner. And so we have here the whole population of students coming ill-prepared from the school and then engaging in healthcare services in adulthood. So we would really love to hear from families about their thoughts and perspectives and experiences in regards on how genetic healthcare is taught at schools. And we hope to use this information to create similar resources as we created for healthcare for schools so they can teach this more accessibly.
No, so that's the end. Emma, you need to finish on time. So I'm going to tell myself to finish on time and wrap up, and we will welcome any questions, or also please do reach out to us if you've got any questions.
I'll say something. I always say something. That's why you like it, because I just talk the leg off a chair. You know that I've been watching this journey of yours for quite a while now. I think we connected originally back in 2021, Emma, positive and negative at the time. But the things that were really good about this is the acceptance and also the inclusion of people with disability and listening to their voice, which I spoke of earlier today. The voice of people with intellectual disability is actually extremely important for parents, caregivers, clinicians, any other allied health professionals. And some of these resources are really good for our young adults and so forth to learn from. And I would say to everyone, really take these on board, share them. You don't even have to say these are because they're to help you because you have an intellectual disability. It's just an easy read book. So you just have it lying around, then they can use it, and then they can take themselves to the doctor and they know what to do. So that's why they're really, really important. So thank you. And videos, the videos are great too that you've done.
Thank you so much, Maria. And you just sparkled one thought in my mind. And that is when we did the interviews initially, but also now we are doing the interviews for the big national study, and we already took over to 20 people with intellectual disability. People keep on telling us they actually want to learn about genes and genetic conditions and things that are these topics. And it doesn't have to be directly relevant to them and their condition. They just don't get that opportunity. And so this is the way, this is an opportunity to do it accessibly.
Brilliant. So I think we're now going to try and get.
Somebody said, what do you do when your doctor seems to not hear or dismiss you when you express your health concerns?
Well, one of the big things that people told us, and I will answer in a bit of round circle, but when we were developing these booklets, one topic we didn't think about is how you make complaint when you are not happy with the healthcare. And people told us we need to know how to make the complaint, so that become a big part of it. So I think when doctor dismisses and the health concerns, it's really important to push back, to really bring out the Australian Charter of Rights of all patients. I know that I didn't say the name correctly.
Patient Charter, yeah.
Patient Charter, thank you. It's very good to bring advocate. So I sometimes come as an advocate with my friends who have intellectual disability to really speak up and put the pressure on the medical practitioner. This is though very hard for people with intellectual disability because they have most of their life they have been really kind of put down, and we keep on repeating them as teachers, medical professionals, that they are not the normal students, they are not the normal adults, which is damaging for people's self-perception and self-concept. So it's really hard to stand up and speak up for them. So, but getting that awareness, like people were telling us in co-production workshops, when they saw the second video, take two, which was based on people's recommendation, what they would like to see, they were saying, oh my God, I didn't realize that my healthcare could look like this, that I am actually now going to ask for this. So they were so used to the crap they were coping that they didn't even think about speaking up. So I know it's not exhaustive answer, but, and Emma will maybe add something. No? Yes.
No, that's really good. And I'm very conscious about time. So I'm going to cut short the talk that I was going to do and just show 3 slides, which is maybe just linked to that. So really, I wanted to highlight some new resources that have come out in Australia that may be helpful where you're having those discussions and you feel your healthcare rights are not being met. And in particular, as a parent or an individual with a rare condition, that you're not being listened to, because sadly we hear that so much. So my disclaimer here is I sit on the Medical and Scientific Advisory Board for Rare Voices Australia, which is our national peak body. And I just wanted to highlight that there is these new resources. So there's a rare helpline and a rare portal where you can go to get information to help navigate through the healthcare system. And we launched in federal parliament in the rarest day of the year, February the 29th, our new national recommendations for rare disease healthcare. And a lot of those go through the rights of people, and they may be helpful to have that conversation. So I've got some copies of these as well, but I just wanted to highlight. And for any clinicians in the room, this is my last slide. We have a new Project Echo, which is we're just starting next week, which includes topics around rare disease, including how to partner with your patients, how to make sure that we're addressing the mental health and well-being needs of all of our patients and their families, which is our number one thing that we're hearing, and also how we do that in a culturally safe and appropriate way and link people with clinical trials and research. So I can send the full slides to everyone, but I don't want to take up any more time from the amazing speakers we've got. And Maddie, I'm just wondering whether you're there and whether you'd be able to share your screen and we'll have a go.
Absolutely. Let me give it a go.
Oh, and just while you're there, sorry, I think there was was there a question? Yes, there is actually some great easy read resources about blood tests and also some information about helping support people. And I can send those maybe to Maria and send out. We haven't done it, but we can share those with you. Yep. So Maddie, we're seeing a slide, but we're seeing them at the moment in, yeah, you're doing it. Yep, fabulous. So I would absolutely overblown to be introducing you to Dr. Madelaine Dells, who is a consultant psychiatrist who, despite our health system, is managing to see young people and adults with intellectual disability to address their mental health and wellbeing needs in a strengths-based way. And I say that because our health system doesn't make it easy, does it, Maddie, for people to access amazing people like you. So over to you, and hope you can share your advance through.
Wonderful. And thank you so much for the opportunity to present here. I'm feeling very underqualified after those wonderful, wonderful talks. And I think a lot of this is very much kind of focused on a sort of more simplified general kind of approach to mental health. And generally, it's an approach I use across all my practice, both with and without people, for people with and without intellectual disability and with and without genetic causes of intellectual disability, because I think general mental health care is pretty similar. So I just wanted to acknowledge that this presentation is occurring on the unceded land of the Gadigal and Bidjigal people of the Eora Nation, and I work and live on Wiradjuri land and would like to pay my respects to all Aboriginal nations and their elders, past and present. So mental health is a complex interplay of biological, psychological and social factors. And while 22q syndrome does have an increased risk of mental health conditions, risk does not mean mental health mental illness will happen. And the protective strategies for mental health, such as coping, improve well-being regardless of our genetic loading. I also wanted to put in there that mental illness is very treatable, and that even if it does happen, we look at medications, look at strategies to manage and roll along with life. So one way of looking at mental health risks is the biopsychosocial model, which is taught in across all medical spaces. And I think a bit of an introduction, or you guys probably are well aware of this, particularly the biological space. Yes, it's known to have an increased risk of ADHD, mood disorders, anxiety, and psychosis when you have a 22q deletion. And psychiatric presentations can be complicated by difficulties in receptive and expressive language, which are noted as 22q. And we had that wonderful talk on communication, which clicks quite nicely into this. As these wonderful talks have gone over, it can 22q can present differently and uniquely in every individual due to a combination of factors which influence gene expression and phenotype. And we had that fantastic talk from Donna, which went over all the details, but I see that every day in every client that I see. And so I think that's something that we need to keep in mind. Everyone is an individual, and everyone reacts differently to their environment. And I think if we were to say that, 22q meant this specific thing, we would be really doing a disservice to all the wonderful clients that we see. Medications can help with symptoms at times. These include antidepressant medications and antipsychotic medications, along with treatment for ADHD. A psychiatrist can help with this, but it's very much an individualized approach is the best with every person that we see. So psychological approaches. Psychology is the study of our minds, so internal image, belief, imagination, speech, consciousness, and thinking. And looking at ways of thinking and our underlying beliefs can build resilience and improve well-being. Regular psychology sessions with a stable psychologist can improve understanding and support well-being, as well as give an objective outlet and perspective. And I think that having someone who's stable, who can kind of have a think with us around the way that we're interpreting our world, can be really helpful, both in recognizing any changes, so having it as a stable support so that we can flag, oh, something's a bit different if we are concerned about mental illness arising. But also just generally, it's helpful to have someone to talk to sort of build our strengths and our emotional regulation strategies. Psychologists can adapt and modify approaches to make treatments for each person, depending on their understanding and the way that they think. And psychology sessions can be delivered in person, via video conference, or on the phone, or through online chat. And there are lots of options. And I think it's important to flag, because there's a range of understanding and a range, as we've sort of heard today, a range of sort of understanding, but also cognition, and having someone who can adapt and work with people that actually allows you then to target different interventions depending on where you're up to in life, and that's throughout life, from a very young age to when you're much, much older. So similarly, our environment and social connections throughout our life can influence our ability to cope in stressful situations. Building good relationships can begin during our mother's pregnancy and extends throughout our lives. And this happens just regardless of our genome. And what we've seen and what the evidence is that practically positive social connections can have significant flow-on effects, including increased exercise and better diet, increased ability to manage stress, better health, better sleep, improved health with a reduced risk of stroke, dementia, heart disease, depression, and anxiety. So putting this all together, Mental health and mental illness is a combination of biological, psychological, and social factors. And what I think is most useful is to kind of view this and think about, hey, are there areas that we could potentially intervene to improve to improve people's mental health, but also to reduce their risk of mental illness? And this is across all the clients I see. So sorry, I should have introduced, I see people with intellectual disability across Western New South Wales and across the state. I also see people without intellectual disability. And so this is something, like as I said, is more generalized for all of us. So I also wanted to discuss sensory sensitivities, which is something that I find incredibly useful in delivering and sort of supporting people's coping and well-being. So sensory sensation is something that connects us to our environment, and understanding our sensory profile and sensory preferences help us and others to support us when the environment is overwhelming. This is something I do with people with and without disability, with and without 22q. So visual feedback, for example, you may find if you walk into Chemist Warehouse that it is incredibly overwhelming. And that is a deliberate decision that they have made to make it visually overwhelming. And in order to overwhelm our cortexes and make us buy things impulsively. But similarly, if you look at pictures of the ocean, if we sometimes see repetitive things on YouTube that calm us down. So everyone's a bit different in the way that they have sensory processing, but particularly that can be a way to calm people. And similarly, hearing sometimes sounds are overwhelming. I can tell you that our sensitivity to noise can vary depending on our emotional state and the demands upon us. So similarly, I know that different people are sensitive at different times, and I certainly am more sensitive to sounds in the morning when I'm trying to get the kids ready for school. And everyone's different in the way that they process things, which is why sometimes noise cancelling headphones or playing favourite music, that kind of thing, can take our minds off things when we're finding it really overwhelming. Taste, similarly, different tastes that can be calming or can divert us and distract us. Smell is at the base of the brain, is really linked into emotional processing, and favourite smells can help us calm. Touch, again, different sensations, scratchy tags on our shirt, like in water, just generally soft or hard objects can help us calm. Interoception is the idea of our own understanding of our own bodies. And so people may find, particularly people with autism, but also just generally, we can have a varied level of understanding of our own internal senses. And so what you may or may not get is people not understanding when they have physical pain, and that coming out as behavioural disturbance, or having, for example, the understanding of being distressed may or may not be present. And some of the strategies that we can use through psychology is to recognise our own feelings when we're feeling upset. Vestibular, things like swings, movement, can be calming and can help to make us feel better, and as can proprioception. So often this is one that we see a lot, is that people punch walls when they're upset, and that's actually getting proprioceptive feedback and they feel immediately calmer. But if we can divert people to things like trampolines or push-ups, that can make them feel a lot better. This is my favourite thing to give everyone, which is a QR code linking to 365 ideas of ways to calm us down. or get our mind off things. And that is fantastic. I give it to everyone because 365 ways, there are some of them are ridiculous, but some of them are positive. And everyone will find one. Mood rating apps, this is a very limited list that my superhero nurse, Erin, found. I think that having an idea of where our mood is up to can allow us to detect when things change, and implementing, if there's one that you like, can be really protective, because if we can intervene as soon as any change happens in our mood, then we can really treat early and, you know, have a look at biopsychosocial approaches to feeling better. And that's a really protective thing. So if we do think that there's something going on with our mood or with our kind of thoughts, there are lots of different ways to get help. And a GP is a really good start, because there's lots of reasons biologically that mental illness can occur, or we can have mood changes. So some, you know, general physical screening is really good. Locally, there's community mental health teams in every local government area. And this is in New South Wales. There's the Mental Health Access Line. There's also, if for people with intellectual disability, there are specific specialist services, and these include specialist intellectual disability health teams, and SIDMOS, where I also work, which is the statewide intellectual disability mental health outreach service. This link goes to a whole list of mental health resources, which I think is helpful to keep on hand. And please reach out if you would like more information. I did have a plan to be there in person, and I have a whole lot of various sensory toys that I was planning on handing around the room. But tragically they're with me in Orange because Qantas cancelled my flight. But they're from Kmart. They cost like $1.50, $2. And sometimes having them around in your house can help people calm down.
Thank you so much, Maddie. Absolutely beautiful. And yet I didn't mention that poor Love had her flight cancelled last night, but she absolutely would have loved to have been here. So thank you so much, Maddie. And I could have done with one of those when the people in the lecture theatre before us didn't leave on time. Yeah. So just opening up to any questions. I'm just going to check the chat as well. Anyone online got any questions, or anyone in the room for Maddie? Maddie, would it be all right? I was going to say, are you happy for people, if they've got questions that have watched this online, to maybe reach out to? Yep.
Absolutely.
Okay, brilliant. Fabulous. Okay. It's been a long afternoon and so much information. Yes.
You can come back on the screen, Maddie. Oh, Maddie. Hello, Maddie. It's Maria. Hello.
Hey, how you going?
Yeah, I'll jump in the screen. Hi. Just a quick question for our families here, and you know that I've probably asked you this multiple times. The pathway, as you said, to access a psychiatrist, especially for intellectual disability, I know you do adults, but it is through SIDMOS and the Kids Hub. But the waiting times are quite huge, aren't they? Let's be realistic about and talk about how that actually operates. That's my question.
It's a tricky space, and I think there aren't a great deal of psychiatrists who have expertise, but I think they certainly exist, and SIDMOS and the Kids Hub are tertiary services. They can support psychiatrists in developing skills in working with people with intellectual disability. Psychology and psychiatry is really, it's a bit of a speed dating game, in that you might find someone who, it's just about finding people who you click with, and whoever you can get, if you can find someone who you feel comfortable with, that's fantastic. I think like there are public services. So I run the intellectual disability mental health clinic in Western. So we're a locally based service. And there may be community mental health. There certainly are fantastic community mental health psychiatrists who are absolutely wonderful at providing care. And you might be able to find them otherwise privately. I wish I had an easy option to suggest that GP, you can also do telehealth and see a psychiatrist online as well. And just let us know at Sid Moss if you need any help.
And I don't know whether it was on your QR code, Maddie, but there's in New South Wales at least, isn't it? There's that new website where people can come in as a person with intellectual disability or as a parent. Is it called IDMH?
I think it's IDMH Connect.
Yep.
So it's
IDMH
in the
Connect.
list, and that's a national support service. It has a full list of various options for support. And yeah, that's a really good start. And you can click through as a person with intellectual disability and or as a parent. Yeah, it's really, really helpful. I think there might be a question about whether people with 22q metabolize medications differently. And it's an interesting question. I think that it's not a simple process. With psychotropic medications, I always tell people that you're the expert on your body and you let me know if there's a problem. And I think that there's no clear guidelines of anything that we shouldn't try, but it's about finding a clinician who you feel comfortable with, who to look and have a chat with you about what your symptoms are and suggest medications which you may or may not wish to try. And if you have side effects, I would strongly encourage you to go to your clinicians and talk to them about those, because they can then have discussions around other options. Don't know if that's a...
Thanks, Maddie, that's great. And I was just trying to show people, I hope that's sharing. Are you seeing the Intellectual Disability Mental Health Connect? Is that on people online? Can you see that? Fabulous. So there's information, tips, and sort of how to find services. And I also just wanted to highlight as well some resources that are new. If you come along here and you go to, oh gosh, this is annoying, isn't it? It's like watching people drive, you know, from the, come along. Oh, I'm going to give up in a second. Anyway, there are some mental health resources. It's just under here. And it's, oh, okay. Doesn't want me to do it, does it? Because we all want to hear honey, but I'm going to really quickly do it. Come along here and you come down here and there's some resources here about mental health and well-being. They include an easy English version, not easy read, but easy English. I'm trying and I'm giving up. Here we are. So these digital mental health fact sheets, and they highlight some of those kind of digital resources that Maddie was talking about as well. So for example, MindSpot, and there's someone as well for young people and for people with learning difficulties as well. All right. Brilliant.
And we also have Central, and I send a lot of our clinician families directly to it because it's one like your amazing. I follow your page, and yeah, it's great to have that.
Yeah.
So lots of online things. If people don't want to talk to someone in person, they can also go online and fill out some of those.
I just realized I should have given you, but if people couldn't hear online, they were talking about resources on the Rare Disorders New Zealand website for mental health, including those digital ones. And I think, like we mentioned before, a lot of it is about destigmatizing, that it's really important to recognize that. Okay, any other questions?
They're getting there. Yeah, they're getting there. And through the AADPN, the Australian Association of Developmental Disabilities medications. Yeah, right. Yeah, they've got a lot of resources, and you connected with. Yeah, I'll send you some details. Yeah.
So Honey, did you want to give like a lightning? What did you want to do? We've got 15 minutes
I don't
left.
mind. I can do a lightning key points so long as people are happy to put up with my squirreling through the slides.
I think people would be delighted is the response we're getting from the rooms. That would be beautiful. So I'm hoping you can share your screen.
Does that work?
Not yet. Oh, yep, starting.
There we
Drum
go.
roll. Yes, looking beautiful. And we've just got it in not yet presenter view, but it's getting there. What a cutie.
There you go. Yeah.
Beautiful. Over to you, Honey.
She's pretty cute. Okay. Well, thank you for asking me to present. This topic could be as long or as short as you like. So first of all, I'd like to pay my respects to traditional custodians on the land on which we all work, talk and live, and the land of the Gadigal people in Sydney, where you are, and I work on the land of the Yugara people, but I'm from the lands of the Inangai people of Western Queensland. So I also acknowledge and pay my respects to Aboriginal and Torres Strait elders, past, present and future, and to those attending this meeting. I also am the director of a clinical trial centre for trials in rare neurodevelopmental disorders, and we run lots of trials in various rare developmental disorders. None of that money comes directly to me, but rather to the unit to fund the trials. So a little bit of background, as some of you will know, we've had a clinic here in Queensland in various iterations since about 2008. And during that time, we've seen about 300 plus children through the service, many of whom are young adults to even, dare I say, in their 30s these days. I totally agree with the comments earlier that, in fact, the amount and number of children with psychosis is vastly reduced from what we actually see reported in the literature. And as Donna said, I think this is heavily biased towards the people who initially did the reporting on that. And indeed, of the children presenting with psychosis in the last year, they were all brand new diagnoses. The other thing I think that's important to really think about was that slide that Donna showed about how complex these children are and how many people you need to see and how many subspecialists may be involved. And I think the whole idea of networks functions on many levels, okay? You know, families often feel quite lost and isolated when a diagnosis is first made, but the focus shifts with ageing and differing priorities. And I do believe that families find it somewhat supportive, I hope, in terms of having a clinic that they can go to at different ages as priorities change. Seeking help can be a battle, and there are lots of stuff to take in. There may be poor coordination. We know that there are problems with integration of care within the health system, going from primary care, which is your GP, nursing, through to local care, local paediatricians, and then to expertise. And we, in a couple of different rare syndromes, and I'd like to think we can get there with 22q as well, is thinking about this concept of virtual networked expertise and a kind of phone a friend, you know, so that the paediatrician in X city in, you know, the back of South Australia can actually ring somebody who's seen multiple children already. But whatever we design needs to work within the health system, which is very different to other systems around the world and quite complex in their private-public aspects. The ability for us to get, you know, cognitive assessments frequently is really challenging within the public system. And so how we think about that can be really important. It's important to think about the child at the centre, and the people wrapped around that child will change with different ages. And that's why we actually, when our funding got reduced, when the two hospitals came together, the thing that we fought really hard for was a nurse coordinator for the clinic. And we know that from other disorders such as Prader-Willi syndrome, where they did some lovely research in the States demonstrating that a nurse coordinator for the syndrome actually reduced the number of hospitalizations, the number of emergency room visits, the number of missed appointments, missed school days, etc., etc. So that care coordination and navigation is absolutely paramount. The size of Australia means that actually, virtual networks is probably the way to go for many of us to get adequate access. During COVID, I think the uptake for virtual care has improved a lot. And certainly we've seen kids in our clinic from remote Western Australia, from New Zealand, from the back blocks of New South Wales, Queensland and the Territory. So there are ways and means to work around this, but I do think virtual networks are probably the way to go. As you all know, the needs of growth and lifespan change, and the priorities are different at each age. So you've got that prenatal, perinatal, preschool, home sort of graduating into school, and then the challenges that come with school into young adulthood. All of those things are really important. And then you've got numbers of other people involved. So people making diagnoses, you've got siblings, families, and then planning for adulthood and how you then fit into the community. Now, one of the things we talk a lot about intellectual disability, but there's a vast number of kids with 22q who do not meet criteria for intellectual disability, yet have multiple challenges that mean that life can be really difficult and challenging for them. So how best do we support those, particularly as they transition into adulthood? And I think that's really about setting up good networks for them. I really like this Bronfenbrenner model, which is a way of thinking about the child in the middle of a number of systems. And when you think about it, I don't know if you can see my pointer, but the child exists in a number of microsystems that include family, school, health services, etc. And then what happens, and we call that a sort of horizontal integration of systems when you go around. Yet there are different levels of system as you go out. So there's more exosystem, which is extended family, extended community, macro systems, which is much more about culture, and then environmental changes over the life course. So there's a lot of systems involved. But as clinicians that work with families and children, we work with these systems and networks to best support the child. And we need that integration of care, that sort of horizontal care, what's wrapped around the child, and then that vertical care from what's happening in the home and the primary care network, right up to the absolute pointy end, say cardiac surgery, which can only be done in a particular place. These systems will actually change at different times, and I think that's where, particularly for 22q, navigation is going to be probably one of the best things for us. We have lots of international guidance, and the work that Donna's team and others internationally have done are really absolutely informative and supportive for us. Sometimes we need to translate this to the Australian system, but it is translatable very easily. There is challenges, I think, with the way our disability system is set up in terms of being able to access some of the supports that we might really benefit from for these kids. And it's really about how that funding stream happens. And I actually think the redirection of some of the money that's gone into the NDIS for differential purposes will really support kids with 22q who might not have intellectual disability to access foundational supports that they actually really need. So I do think that re-injection of funds back into the system may well support these kids better. Now, the networks, for research are really important, I think, around where we can go. And I've seen this growing very slowly in Australia, I have to admit. The ultimate sort of goals really are to get longitudinal data, often from clinics with standardised pro formas, and linking that to biological data, which is what places like CHOP do really well. I think we have real opportunity in Australia, particularly with the opening up of the Perth clinic, to really start to harmonise the data that we collect and then use that platform to actually lift up into a de-identified data set across Australia. We've commenced here and just beta tested the pro formas and are working with Perth to standardise that at the moment. Clinical trials are definitely coming here, and I'm well aware of at least 2 that are likely to turn up in the not too distant future. So we need to be ready for those. There's lots of different ways we can do clinical trials, and it varies depending on the medication and where that medication is, and whether we're repurposing medications that are already used or whether they're brand new medications. We can either treat the symptoms or the genetics. Treating the genetics in 22q is really complicated because there's lots and lots of genes involved, and it's very likely that we'll probably have a symptom-based approach first. So when we network systems, what we tend to try and do is collect the data in individual hubs or nodes as a network, and then loop that into a de-identified data set. And that's how we get the numbers we need to actually impact things. So at the moment, we're trying to harmonise data. The more clinics we can involve, the better. But then we can link them longitudinally. So that's how I really see that research networking happening. And we're working with WA in particular at the moment. I just sort of pop in something quickly about clinical trials because I do think they're coming. This is kind of where we sit. When people are repurposing or finding new medicines, there's lots of work that goes into it. And so what we see is a lot of basic science research, lab-based work, then often some preclinical testing, which is either with animal models or these days with cells that are made into brain and neuron networks. Then we need to test them on actual patients because mice are really different. They all have exactly the same genetic makeup, but they don't have the variation that humans do. So we need to try and work out whether it actually does work in humans. And often what we need to do then is, take the population and then randomly either give them the medication or give them a placebo, which is a bit like a sugar pill really, and then see if there's any difference between the two. And sometimes we'll swap them over to test them again. So they can be really helpful ways of trying to work out whether a medication works. And even with something like 22q, most of the medications we use are very symptom-based and are based on our experience with the symptoms in other disorders. They're not specific to 22q. So we learn every time we try and manage or treat a patient with 22q. There are already medications that we use for ADHD, anxiety, etc., but they're not specific for 22q. But this doesn't mean there won't be medication in the not too distant future that will treat some of those symptoms, certainly a bit better than we can at the moment. We do need the infrastructure ready for this to happen. And then I think the collaborative planning is really important with networks. So coming back through all that research networking stuff, if you come back to the networking around the child and that planning moving forward, I do think the networks can be really important in terms of research and directing research. So when we do research in rare disorders, what we will often do, and I'd really like to try and drive this forward with our 22q community in Australia, is start to actually get you guys to tell us what sort of things you want us to be looking at as a research network for you. And then thinking about how do we look at it, how do we intervene, What are the things that are important to the community? And then using that continuous cycle of improvement to drive change, both within the clinical space and certainly with outcomes moving forward. So, yep, that's probably me done, I think, in the interests of time.
Beautiful. Thank you, honey. And look at that, 5 o'clock on the dot. Oh. But I will just open up to see if there's any questions from the room.
I'm coming down tomorrow night, so if anybody wants to catch me there, I'm really happy to talk there.
Go and grab honey. No question.
Oh, do you want me to ask?
Well, I'm just looking at you expectantly.
Okay. Here we go. It's easier. Thank you, honey, as always, and thank you for coming tomorrow as well.
I do have to apologise. It's a very exciting day in Queensland. We've launched the first of our centres for intellectual disability mental health. We have not had any before. So it's been a really big day, and there was no way I could get a plane between 12 o'clock and be there by 2.
Well, I don't know. Come on. We'll have
I'll be there tomorrow.
Congratulations. We'll have a champagne for you tomorrow.
Excellent.
With the virtual, the virtual, you and I have talked about this. I should look at you that way. You and I have talked about this on multiple occasions about the virtual style of telehealth or health treatment. I think it's still a fair way off because obviously the different state systems, but we are closer. But just something for the families, because a question came up the other day and you just mentioned it. Are families able, like let's say someone from New South Wales, Victoria, able to come to the Brisbane clinic? That's something. She's eating. Hang on, let her finish that chocolate.
What we tend to do, largely because we're not funded and we're not supposed to take interstate referrals, what we tend to do is do an initial telehealth with the local clinician. So we did that with some patients in New Zealand, and I've certainly done it with some clinicians in Western Australia as well, and certainly done it into general practices to try and support, particular investigations or management or things that they were finding challenging at the time. We tend to run that much more as a one-off consultation liaison rather than a continuing care situation, mainly because our nurses that do our local coordination don't know the local scenario, and we're relying on the local people to actually support that local navigation. But certainly we do take some referrals. We're a little bit selective, and sometimes we'll direct to local people we know that we think would be a good fit and have the right sort of approach to managing complex developmental and mental health issues.
Okay, thank you.
And I might mention,
does that answer your question?
Yes, it did.
Beautiful. She had to leave, but we had a lady here who's Nika, who I work with. She's a rare disease navigator. So we've got 2 of these at the moment as part of a pilot project. We've got one in Perth and one here in Sydney. So again, it's the sort of thing where these kind of roles, and I think that was so important what you raised, that nurses are the absolute glue and the key people. And it's really, they can do so much. And so one of those things is if you've got a nurse navigator, then they can help liaise and get the expert advice and then help with that local care coordination, because you do need to be able to help support within the health system that you're in as well. So it's a way, I guess, we're trying to think about bridging those gaps. Any other questions? And yes, this has been recorded, and I just need to work out how to get it to you. I just need to work out how to get it to you, but I will get it to you. Yes. There is a question.
So, honey, really lovely presentation. Wondering if there's any update on the Zynerba study.
There is. I understand Zynerba have had some challenges in producing enough product, Donna. They are committed to actually running the study, but I think they're struggling with producing enough product right at this minute. They're very close to finishing the Fragile X study, and I suspect once they've finished that, they'll be able to move on the 22q. But last I heard, they're very keen to progress with it. But it's a product limitation with their transfer of manufacture to the UK.
Okay.
Does that answer your question?
Oh, I think so. And shall I hand to you to wrap up? Would you like to? Because you have beautifully put this together.
Oh, I didn't put it together. I just wrote an email and suddenly it happened. Thanks everyone for coming. Thank you everyone that's online. Special thanks to Donna for coming. You know, I heard her tell a story today about how she came here, and apparently all I need to do is just continually send text messages at nighttime, at her nighttime, and to get annoyed and go, oh, okay, I'll come. So yeah, that's good. So we'll do that. Everyone, if you want Donna, just text her in the middle of the night. No, seriously, the talks have been fantastic. Emma, as I said when at the start, this collaboration, and I do like the word collaboration, and from the minute I met you, I think that's all I've talked about in every presentation I've ever done. Collaboration, unification, and the voice of our people and us. Laura, we've got some great work to do. And no, Donna, you cannot have her. And you cannot have Emma. Sorry, they're all staying in this country. So thanks, guys. And here's to our 30th anniversary. And we've got the gala dinner tomorrow night. Honey, don't drink too much champagne tonight because you've got to do that tomorrow night. Congratulations on the new centre. Maddie, thank you so much for your time. And also GeneEqual, really lovely. And those resources are going to help us. So here's to 30 years. I'm going to end the meeting now. So if anyone's got any last words. Oh, there's messages. Hang on. I can't read them. I've got no glasses on.
I've got multifocal contact lenses. We've got to thank you and yeah, lovely, nice messages.
Okay.
Beautiful.
Thank you.
Thanks, everyone.
Oh, I'm popping to myself.
Pat on the back.